Go ahead, sir.
Namaste and greetings. I, Dr. Sauravi Ghimire, Research and Communication Associate at IMPRI, Impact and Policy Research Institute, Prabhav Ev Niti Anusandhan Sansthan, Nai Delhi, extend my warmest welcome to you all to IMPRI #Web Policy Learning. We are gathered today for an online immersive certificate training course on Perspectives on Gender Through Healthcare Lens. This training course is organized by Center for Ethics, Yenepoya, deemed to be University, Mangalore, and IMPRI, Gender Impact Studies Center, GISC, New Delhi. Let me welcome all of you for this enlightening deliberation. And now let me introduce the course briefly. Historically, the world over, there has been a gender differential, and some countries have proactively worked in reducing this gap, ushering in a semblance of equity. In India, there are more engaging discussions on gender in social science departments and centers on women's studies. Mainstream health universities and medical colleges and healthcare institutions have largely stayed shy of this, despite the overall progress in medical and healthcare institutions. These still lack the thrust on gender sensitization, equity, gender responsiveness, and gender audit to make gender in healthcare more mainstreamed. Healthcare textbooks still propagate gender stereotyping. Graduate and PG students are not sensitized to gender diversity. Hospital wards and personnel find themselves at a loss as to how to handle transgender people. In order to bridge this gap, the Center for Ethics at Yenepoya, deemed to be University, Mangalore, and IMPRI, Impact and Policy Research Institute, New Delhi, through its Gender Impact Study Center, or GISC, are collaborating to conduct an online immersive certificate training course on a wide range of well-curated topics over 3 consecutive Saturdays, starting from 4th June 2022. The expert resource persons have great experience gained in the field along with their expertise. The topics cover a wide array of gender canvas, starting from gender in the human dignity and respect for persons to recognizing the rights of transgender persons. This 3-day training program has an excellent panel of members who will be sharing their knowledge on the above theme. The patron of the program is Mr. Farhaad Yenepoya, Pro-Chancellor of Yenepoya, deemed to be University. Our course advisor is Professor Vibhuti Patel, visiting Distinguished Professor, IMPRI, New Delhi. Former Professor, Advanced Center for Women's Studies, Tata Institute of Social Sciences, TIS, Mumbai. Our conveners are Dr. Veena Vaswani, Director at the Center for Ethics, Yenepoya, deemed to be University, Dr. Simi Mehta, CEO and Editorial Director, IMPRI. And we are very fortunate to have distinguished training experts, Professor Mala Ramanathan, Ms. Brunel D'Souza, Dr. Padma Bhate Diosthali, Ms. Sangeeta Rege, Dr. Ketki Ranade, Dr. Amar Jasani, Dr. Aparna Joshi, Ms. Renu Khanna, and Professor Anita Ghai. So before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be a Q&A session after each presentation. Share your questions on the Q&A box only and not on the chat box. The questions must not be posted as an anonymous attendee. And please ensure that your questions are precise and refrain from making general comments in the question to save time. Now, I would like to invite our course advisor, Professor Vibhuti Patel, to initiate the program with her opening remarks and initiate the expert sessions. Ma'am, the floor is to you.
Thank you, Dr. Shaurvi. First of all, I would like to
IMPRI, Dr. Veena Baswani, Dr. Arjun Kumar, and renowned resource persons and esteemed participants of this immersive online certificate training course on perspectives on gender through jointly organized by Center for Ethics, Yenepoya deemed to be University, and Impact and Policy Research Institute, IMPRI Web Policy Learning. We are thankful to the patron of this course, Sri Mohammad Farhaad Yenepoya, for his support and encouragement. It gives me immense pleasure that our collective effort has resulted in this well-organized workshop. We are all aware that sex and gender are closely related constructs. While sex signifies individuals' biological presentation as female, male, or intersex, gender represents socio-culturally constructed assigned roles, behaviors, attitudes, duties, rights, traits associated with being male or female or transgender. Queer studies has challenged this famous quote of the gender studies that all of us are socially constructed. That's a very different, very, very important concern that also we need to address. The sets of expectations and thoughts, philosophies and social theories about how women and men should think, behave, communicate, the code of conducts that are determining do's and don'ts are called gender norms. And they shape human personality, identity, self-perception, perception about others, and health across life cycle of human beings. Thus, healthcare, and health outcomes need to be understood in the context of gender social determinants of health and healthcare, as gender norms invariably engender power imbalance between two individuals, groups, or communities, where masculinity is associated with higher status and higher social worth, while femininity has lower status and lower social value. Power relations based on domination-subordination relations are central to an unequal and harmful gender systems formed on the basis of intersectionality, creating different modes of discriminations and privileges, discrimination for one section and privileges for the other. This gender inequalities and restrictive gender norms have great bearing on health status, healthcare delivery, and health outcomes. Gender norms defined by misogyny and hypermasculinity can keep the disadvantaged from challenging the unjust power distribution. They can discourage people's self-actualization and can be cause of punishment for those who are supposed to be quote-unquote deviants. For example, transgender persons, boisterous women, non-aggressive men, gender minorities like LGBTQIA+ communities. Intensely entrenched gender norms are imperative to change, impervious to change. And for example, son preference and daughter aversion in South Asia has existed for centuries. And currently we see how the scientific technologies are used for selective elimination of female fetus. People's normative views, beliefs, attitudes are solidified by gender stereotypes, internalized by civilizations over centuries. Fear of retaliation, social rejection, persecution, isolation, ostracization make people put up with these harmful gender norms. And these gender norms vary across cultures, generations, geographical locations, socio-economic and historical contexts and populations, and that here lies the ray of hope. We can change this unequal gender relations. As a result of historical legacy of gender-based injustice, harmful health consequences of gender inequality fall most heavily on underserved sections of society facing intersectional marginalities. Gender norms can be created and reinforced at any level in social ecology and may influence health along 5 gendered pathways. Gender differences in socialization pattern, gender health-seeking behavior, gendered impact on accessing care, and gender biases in health system, and gender biases in researches, institutions, and data collection that we do. Patriarchal mode of healthcare system where doctor is treated as a father figure, nurse as a mother figure, and patients as children. I think that also defines a very, very entrenched hierarchy that we are facing in the healthcare system. So causal estimates of impact of gender norms on health have come to the fore during this last 2 years of pandemic. We have seen how healthcare outcomes have been affected differentially according to gender. Research evidences point to association between gender norms and health outcomes is very strong. For example, norms that deprive women of their autonomy, bodily integrity, escalate gender-based violence, or decisions making power, which gets eroded when it comes to family or community or society, that also reduces women's opportunity, or those who are at the marginalized communities, they face high child mortality, higher fertility, lower secondary school education, more corrupt governance, and they and also accounting for impacts of political system and also level of economic development that the country has. So it is very important to understand healthcare system and health issues in the context of this institutional parameters which are created. So unequal gender norms at relational and individual levels have also been found to have consequences on health outcomes. With this perspective in mind, we have decided to have this course, and with a wide range of issues starting from overall health to reproductive health to biases in the healthcare system and medical education, need for gender diverse approach going beyond gender binary, and also new reproductive technology, the question of nutrition and hunger, the question of mental health, and also the health policies and disability rights, all are covered in this course. I'm sure all of us are going to collectively have a very many learnings of this course. And now I request over to Dr. Veena Vaswani. Yeah,
should I, ma'am? Should I start? Or...
Hello, ma'am. Thank you for the opening remarks. Now I would like to call upon Professor Veena Vaswani to share some words. Over to you, ma'am.
Thank you. Is it shared? Can you see the screen?
No, we cannot.
Okay, once again, I'll try.
Share it again.
Yeah. Just 1 minute. Yeah, can you see it?
Yeah.
You can see it.
Yeah.
Go full.
It's in a slideshow mode. It is a working mode.
Is it now in the slideshow mode? Yeah.
Yeah, visible.
Okay, thank you. At the outset, I would like to thank Vibhuti ma'am and the IMPRI team and Mala. They are the strongholds in gender. And when they come in contact, we usually think, it makes me think we haven't done enough. There is lots to be done. So we just thought we'll start this by sensitizing, especially from the healthcare angle, which I have been here for more than 20 years. I bring my own experience as well as that through a research that we are currently doing with the transgender population and what I crystallized from what's happening from a day-to-day aspect. So in short, we talk so much about transgender, but in reality, the access to higher education, access to schooling given, because at 11th and 12th, when they come out, they run away from schools. They're not getting justice in society. They're not even getting love and affection from their family. They're not getting recognition for who they are. And so lives have not significantly improved. So thrust on gender sensitization, equity, gender responsiveness, gender audit, we hear about these terms, but if you ask sincerely, especially from the healthcare aspect, we are quite naive about these things. Except that we have heard about it, we can't vouch for what we have done in this regard. So even the textbooks propagate gender stereotyping. I come from a forensic background. About 20 years before, I attended a huge annual conference where it was told that if a lady comes with a sexual assault history and rape, don't believe her. So this is a kind of teachings that has been propagated that don't believe, then who is going to look at the humanitarian aspect? from the gender aspect, the downtrodden in society aspect, if you are teaching that to doctors. So we have to be very aware that in such inappropriately structured curriculum regarding gender, the justice to the gender through healthcare would be a far cry. Although I could say there are enough initiatives of late, but are they really making an impact? Actually, including schools, colleges. In 2017, we had invited a school teacher from Delhi Public School to speak about her experience with transgender children. And it was very heart-wrenching to know that the parents were very angry with this teacher because she identified the transgender children and their traits, but the parents said, you are encouraging them to become transgender. If you don't encourage them, my children won't be like this. So how long do we still be like ostriches, that you look down and then you say, put your head in the sand and say it doesn't happen here, or put things under the carpet? So that is why I think it's time to look at a new sensitized way when we look at what happened post-COVID to the transgender people and how did they suffer so much, and what the reparations that we are doing, are they really going to address their needs? So starting at the very beginning, because gender is also an identifier. We are what we speak from our profession, and in forensic identification is a big thing. You identify a person from gender, you feel 50% you've identified. But then there is huge confusion between sex and gender, because so far we have been writing gender for sex. So far, it's always gender, which gender? But if I'm looking at it from my lens, it can't be gender, it should be sex. Even that appropriateness has been lacking. People are usually assigned male, female at birth, and that becomes a legal document. And the legal document of late, which is also a national identifier, becomes very difficult when there is a change in gender. This binary of identifying male and female misses out on transgender people. And for a long time, what we don't know, we think they are not important. We just don't have to care about it because they are not in the discussion. So talking of the gender identity and orientation. So gender identity of a male, female, or a girl is what a person identifies. But then when we look at it, it's only the sex, which is assigned at birth. Whereas gender expression as a child is growing up, it's understanding whether it is having the traits of a boy or a girl. That is again different from gender attraction, which gender you are attracted to, a male, a female, or a woman, irrespective of what gender you belong to. And emotional attraction is another thing. But this spectrum of understanding, we hardly tend to make efforts, but we go by what we generally think is what is the sex. Now, as a child is growing up, we make it our effort to go for stereotyping, because we think that we as parents should channelize child's gender. We want our child, because it's male, it has to conform to gender norms, as Vibhuti ma'am was telling. Because we feel appreciated as a good parent if you instill these norms in our child. So as it's growing up, we say, okay, a child has to go for a motorized toys, for a gun, and a girl has to go for Barbie dolls and kitchen and cookware and other things. So what we have been trying to teach the child is what the child takes. And that is how it internalizes a gender. But then for the children who don't conform to it, they start sticking out like sore thumb. So representation of every gender, even when we are talking, it doesn't happen. In the stories also, there's only a male or a female child. We give no scope for transgender. So actually that is not nurturing the child with love and care, giving a wholesome way of gender parenting. Now coming to social identity theory, when we personally identify ourselves, but in a larger context, birth, death, community participations, cultural aspects, we identify ourselves socially. We have a group and we have belong to the group. The moment we belong to the group, the people who don't belong to our group becomes the other. So this otherness creates a differential that we are superior and the others are not so superior. So this great sense of pride that we belong to the group and a kind of disdain that is the other group. So them and us is a process of categorization. So tendency to categorize causes discrimination, whether we like it or not. Supposing we are given seats on a flight, 50 of us get the window seat. And suddenly somewhere they say, no, 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 please swap the seats. All the windows will come to aisle. We start thinking, no, it's as if it was given to me. I'm not going to change it. So this kind of adhering to something because you're privileged. You like that, you want to keep that. But then you look down upon those who don't have it. So us and them gives rise to prejudice. It exaggerates similarities between groups, like all doctors, healthcare professionals, teachers. And it also discriminates between those who are other. We call them the otherness, us and them. So the prejudice, this kind of behavior, makes us feel we are superior and they're inferior for some reason or the other. And that continuous prejudice results in violence, hate crimes, isolation, and discrimination. It doesn't require a huge, big leader to mass transfer peoples into a discriminating people. We just need to have a thought that we are one and they are the other. With such simple thoughts, societies have broken up into fragments. So the identity of the other, social identification reflects the notion that we are like observers from a detached point of view. But our own sense of who we are typically relates us to those individuals around us, and we identify them if they are similar. So this knowledge of external world appears to us greatly is conditioned by what we have learned. That always go with girls, you hang around with girls, go only with these, and don't go with boys. And don't go out at night. So slowly the way of what you have to behave, a norm, becomes a rule, and those who are not behaving according to the norm totally become discriminated. They become stigmatized and the other. One of the philosopher beautifully puts it as, whose face do you see when you see a stranger in the mirror? Is it likeliness to you? Then it is yours. Then you say, okay, come. Well-dressed with a nice goggles and then you put the appearance of a sophisticatedness. Please come in, please come in. You see the face of a maybe uneducated or rural person, not well-dressed, not strikingly male or female. Oh, no. So that shows the difference, that the other person as a stranger is really the other. And this otherness gives rise to a lot of conflict in a community. And what happened to our so-called transgender people, because we always treated like the other and we haven't been able to integrate them in the mainstream during the COVID-19. Because we decide what is normal or abnormal, because we already have a conditioned reflex. We wear this goggle by the education given to us by our parents and the society. So already we are wearing a goggle and seeing others. The lens is not clear. It is totally clouded unless we make efforts to unlearn what we have learned and objectively understand what is human dignity. Are we all not equal? What is human rights? Do we all have equal right? In that case, how can we differentiate a person on the basis of gender, gender affinity, gender attraction, gender orientation? And why do we do that? That's because our lens is not yet clear. Our goggles show a different color and we are happy with that. So the normal or not normal is decided by us. Secondly, the fact that if 10 of us so-called normal people sit and decide this is normal, then we have a kind of superiority complex, which it's also called the Dunning-Kruger effect. So Dunning-Kruger were social scientists, so psychologists who decided that you have a cognition, and with your limited cognition, you think you're far more superior than others. Recall a situation on a dining table. The person who speaks the loudest, he makes most noise, but his upper story could be totally empty. So that metacognition of understanding what we understand, what we don't understand is lacking in many people. And many of these become group leaders. They lead people by the oratorial skills, not by rational thinking. And we are quite guilty of running behind people who speak so effectively, because it is the speech that attracts us, not the content. So as it is, we have to discern between what is the mental content of what they're saying and what is only the sound effect and the sound bite. So that is why we need to reflect on how are we competent to judge, and can we make out Can we make this difference that male, female are only the binaries and the transgender don't come anywhere in the discussion? And then if they come also, poor chap, they should be happy with what they're getting because things have improved for them over a period of time. Said who? This is color blindness. It is complete color blindness to the fact that I see everything normally. If I don't see transgender properly, excuse me, it's not a big thing. So this is a kind of behavior we need to question. What kind of biases do we carry? Do we carry a bias against the gender? Do we carry a bias against transgender or lesbians, gay, homosexuals, or intersex people? Because there's a whole spectrum of them, and nobody told us it's only male, female, but how did we believe with such superiority and then discriminate them who are in the transgender? So how did COVID impact them? The fact that when the largest democracy went, in India especially, or lockdown, the people were least prepared. I say transgendered were least prepared. Similarly were the migrants who did not have a bank account, who couldn't use an ATM. So now the day-to-day bread earning depended on commercial sex and begging. You coop them in a room and what have you done to them? In one room, 10, 15 people, those who were in the lockdown with their parents had a still shabbier deal because parents didn't want them there. And then people were telling, get them out because they're now going to commercial sex, they're not decent people. So this was what was narrated to us. And then most of them also stayed in the rented rooms. After 3-4 months, the rent went on increasing. They didn't have any scope for going, so they had to go to their money lenders. They were literally the money sharks that paid money. So now each of them are having a huge loan on the head, and now they're not employed. And then we had this audacity to think society is normal. We take them to police commissioner and say, please give them job because you announced 10% of jobs for transgender. They said, get the rent contract. Who's giving them a rent contract? Nobody. They are pay 1.5 times the normal rent, but they don't give them a rent contract for the fear that all of them will come and sit here and they will make noise. So this is how they're deprived of normal human dignity, respect for human persons, expression, take up a job what they want to do. They're deprived of all this. And that too because we care, we don't care. We care to think that they're justified because they have improved, in our colorblindness state. So hence, we wanted to bring these issues. So we were lucky to have IMPRI go with us in this call to spread this message. And we were lucky that at the same time, Vibhuti ma'am was there and Mala for a long time has been talking of gender in the university. So, and as a part of our sensitizations, because we are in Center for Ethics since 12 years, and we run 2-year full-time research ethics master's program, postgraduate diploma in bioethics and clinical ethics, and lot of value-added courses. Gender ethics, we just started 2 months back when Vibhuti ma'am was there. But this is not the end, this is just a sensitization. So we are happy with IMPRI, this particular initiative to take it forward, where there's 3 days of well-curated topics, and then people with excellence in their field, experience that they bring on the table, and covering a wide array of canvas of ethical issues, including the human dignity and everything. So with that, I think our journey has just begun. So please be with us, be encouraging to any person you think who is deprived because of the gender minority. Try to ask yourself, have I done this before? Do I carry this bias? So with that, I close my remarks. I think I'm sorry, I may overstep my time. So thank you very much. And I leave it to the Sauravi or this thing whenever you want to take questions. Yeah.
Yes.
Thank you.
Thank you, ma'am, for the welcome address and letting us know about the deep analysis on the relevant theme. Now I would like to introduce to our first expert, a distinguished speaker, Professor Mala Ramanathan, who will be speaking on reproductive health. Professor Mala Ramanathan is a professor at Achyuta Menon Center for Health Science Studies, SCTIMST, Thiruvananthapuram, and also the working editor at Indian Journal of Medical Ethics. Ma'am, please take the floor and go ahead with your presentation. Thank you.
Thank you very much, both Dr. Vibhuti Patel, Sauravi, Veena, and others for setting the stage on gender. It's extremely important that we are all on the same page with regard to gender, because the first talk is about reproductive health. And I was assuming certain basics and understandings about gender. And I was so happy that both Dr. Veena Vaswani and Professor Vibhuti Patel addressed this gap to set the stage on what I am going to be talking about, which is reproductive health. There. And yeah, it's visible now.
Visible, yes, full screen. Perfect.
So this is the usual disclaimer. The opinions in this presentation are my own and do not represent those of the institutions to which I'm affiliated. I'm particularly grateful to Dr. Vibhuti Patel for useful discussions on this topic earlier over the phone. And I'm also grateful to Drs. Tijo George and Sunusi Thomas, because they facilitated the development of certain images from my conceptualization of sexual and reproductive health and gender. And so that is, having said that, I need to set the historical concept of how this emerged. And there is a historical, start of the century, turn of the century, which I'm not going into as part of reproductive freedoms, but let's say that the very strong population control regimes that emerged in the 70s and 80s and really gathered strength in the mid 70s and 80s, both in India and globally, because of the discourse on the Club of Rome, which talked about the rate at which food cultivation grows and the pace at which populations grow, and the twain do not meet. And therefore, there is a need to restrict population in keeping with the ability to produce food. And from that discourse came a very strong global push for population control in the developing societies. And it is from there that the very rigid, and for those of you who have read your history, you would remember that the strongest restrictions were imposed on reproduction during the emergency in the mid 70s, 75 to 77, with a race to achieve huge targets in sterilization. Now, while there was a backlash with regard to, sterilization of men, it did not, stretch itself to sterilization of women. And that's another local reality where gradually over a period of time, the kind of targets that were being set for men in order to achieve, certain coercive policies that were imposed during emergency, we had a target-oriented approach for achieving contraceptive targets all over India, and that gathered strength over time. So while there was an aversion to, a discourse on coercion, coercion became institutionalized through targets being set for achieving certain goals with respect to specific contraceptives. That and the overwhelming emphasis on use of invasive contraceptives resulted in a global solidarity movement with local and global feminists coming together to articulate a discourse on reproductive justice, that bodies of women are not to be used as a means for achieving certain, restrictive goals of family planning or population control, and that women have an autonomous, independent right over their bodies and their reproduction. And that was the reproductive justice movement. And it resonated with Indians who were Indian feminists, who were seeing that this overemphasis on population control was seeking to use women's bodies as a means to achieving these control requirements. And the health system facilitated that process by increasing targets to be achieved by health workers on the bodies of women. And this culminated, there was a very strong reproductive justice movement, which culminated through many, stages into the international ICPD, the International Conference for Population and Development in Cairo. This happens once in 10 years, but Cairo stands as a particular departure where there was near universal concurrence on the need to bring reproductive rights to center stage. Of course, there were naysayers there, including the Holy See and a few other groups, but many of the nations, both developed and developing countries, spoke with one voice on the need to center stage reproductive rights and reproductive health within a framework of population and not population control. And that is what the ICPD mandate for reproductive health was. And that ICPD mandate articulated a reproductive health care mandate. It said, this is the provisioning of being healthcare is the constellation of methods, techniques, services that contribute to reproductive health by preventing and solving reproductive health problems. It includes sexual health, enhancement of life and personal relations, and not merely counseling and care related to reproduction and sexually transmitted infections. This is how the ICPD mandate moved from a reproductive health approach to defining what reproductive health care should then be. And that started the WHO's definition of reproductive health, which was articulated along with that as a state of complete physical, mental, and social well-being, and not merely the absence of disease, infirmity in all matters relating to the reproductive health system, and not merely the uterus and to its functioning and processes. Reproductive health implies that people are able to have, it did not say women and men, it said people are able to have. We've forgotten that in our, by going hammer and tongs after women alone. In its functions and processes, reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if and when and how often to do so. This is the WHO definition, and I think we need to keep reiterating it again and again to bring a focus on people and not target individual groups. And what did we in India? India was a signatory to the ICPD mandate, a vociferous supporter of the ICPD mandate. There were so many of people who will tell you of the sense of freedom and solidarity that was acquired at the time of ICPD. And so many of my senior colleagues have talked about it, of a time when the solidarity extended to belief and faith in each other, a recognition of a need for, girding ourselves up to do the unfinished agendas in India. And the government systems also cooperated with the various NGO groups in that ICPD. And a very good start was made by dismantling the targeted approach to family planning by having a target-free approach. Even as that was going on, we introduced the reproductive and child health program in India, phase 1, incorporating this reproductive health approach in our health systems to deliver syndromic approaches to gynecological morbidity, ensuring that there was sufficient medications to treat gynecological morbidity, addressing, you bringing in a lifestyle approach, the continuing 2005 and 5 to 10, the phase 2 of the RCH program incorporated contraception, dismantling, ensured access to reproductive commodities, universal, and further strengthened the approach to treatment of gynecological and obstetric morbidities by building strength of health systems to deal with various consequences of postpartum morbidity, emphasis on antenatal care. All of this came as part of this RCH program, not merely, and the emphasis on addressing pregnant women from the time they get pregnant to delivery, all of that. Then came the need to include adolescent care and a continuum of care in the postpartum period as well, and starting with the recognition that adolescent women become mothers subsequently, and they are physically disadvantaged due to anemia, lack of malnourishment due to various lack of resources, and the need to include a continuum of care starting from adolescent health to postpartum and older women care, brought in the reproductive, maternal, newborn, child health, and adolescent health care into our programs. And from 2017, we have been having a movement, which I don't know what to call it, I will just describe it, a movement which is focused more on an effort towards a targeted approach to certain districts which were seen as problematic, high fertility districts, focusing on enhancing contraceptive access in those places through a program of Mission Parivar Vikas, adding Antara, the MPA injectable contraceptive, and Chaya, the Centroman, which is a non-hormonal pill to increase contraceptive choice. I will address what this means presently. This RMNCA approach meant reduce unmet need for family planning, which was becoming recognized, but again among eligible couples and married and unmarried, because this was, a baseline in DLHS was found to be 21, to reduce it to 8.8, increase met need for modern family planning methods among couples, to decrease the proportion of total fertility rate contributed by adolescents by increasing age at marriage, and raising child sex ratio in the 0 to 6, which had become alarmingly low in favor of male children, to from the baseline that was seen in 2011 census of 914, which means we had 914 girls for every 1,000 boys, which is remarkably low, but better than what we had in 2001. So what does this all mean? If you look at this focus, married and unmarried, but if you look at our contraceptive package, even what we have included is not like emphasis on male contraceptives, but we have brought in 2 contraceptives which again target women. I'm just taking the example of contraceptive use to give you an example of how gendered this is. Modern method contraception, use of modern methods, which includes, injectables, sterilization for men and women, oral contraceptive pills, condoms, and the IUCDs, intrauterine contraceptive devices. If you look at, the blue color line represents what was happening about 7 to 8 years ago, 2015-16, and the red line represents what was seen in contraceptive use in 2019-21, you see that there is no place where use of contraception has declined. Almost nowhere has it declined. In fact, in most parts, if anything, it has increased. Or in certain parts in South India where you had reached almost as much as you could achieve, it is stagnating. But if you look at the contraceptive method mix, now I want you to look at the light blue color as opposed to the dark blue color. Almost universe, the dark blue line. Look at Andhra Pradesh. There is hardly any. All India, this light blue, the only place where you have male responsibility, you see that how small the component is. I will take the questions later. After Dr. Gopinath, I will address it subsequently in one go. If you look at the male responsibility, in certain parts of India, there is definitely increasing demonstration of use of condoms and male responsibility in contraception. But by and large, look at the strength of that blue bar, dark blue bar, near universal, particularly in certain states, near universal use of female sterilization as the contraceptive method of choice. So I constructed an indicator of female responsibility for contraception. And again, the blue line represents what was the female responsibility for contraception in 2015-16 and in 2019-21 by using the National Family Health Survey data. And as you can see, a significant proportion, if one is ideal, you can see that a significant proportion of responsibility for contraception is taken by women. The women's responsibility over the 7-year period has indeed come down. What it indicates is, since 2015, men are taking some responsibility for contraception, but it is nowhere on par with that of female responsibility taking. You see that there is an overwhelming discourse on the need, including through the mission Parivar Vikas, focus on high fertility states in India. From 2017, 145 districts have been targeted with this program. In certain states, these districts are near universal. But what we see is from 2015-16 to now, the total fertility rate, that is the average number of children born to any woman during her reproductive period, went from 2.2 to 2. That is, on an average, every woman is only having, on an average, only 2 children. And this means in certain states in India, a woman who is now producing a child is not going to be replaced by another woman. That is what the net reproduction rate represents. Every woman who is alive now and producing children will be replaced by another woman. That is not likely to happen in certain states of India. This was the goal of every woman in the 1980 population policy. And if you look at the population policy of 2000, we still see the net new population policy 2000 is to address unmet needs for contraception and to bring TFR to replacement levels by 2010. Well, by 2020, we have reached it. We have reached that. The long-term objective is to achieve a stable population by 2045 at a level consistent with requirements of sustainable economic growth, social development, and environmental protection. Noble as that may seem, you look at the declining fertility across India. If you see below 2, Andhra Pradesh, Goa, Himachal Pradesh, Maharashtra, Punjab, Sikkim, very low, West Bengal, Andaman Nicobar, Chandigarh, all of these are way below the replacement of 2.1. And the TFR has definitely been more rapidly declining, as you can see when you see the red line. So, barring 2 states where there was a slight increase, Kerala and Tamil Nadu, where the change in TFR, which means TFR went slightly up. In these all other states, maximum declines have been experienced all over India. We've had significant declines in fertility, regardless or perhaps because of what is happening with regard to our programs. If you look at unmet need, yes, the decline in unmet need for contraception is about to the tune of 25% in general. However, the unmet need for spacing is declining slower. What have we done with that in that respect? There is still scope for improvement, but spacing could mean, male contraception as well, and we haven't done much in that direction at all. There is a very, very strong gender inequality with respect to reproductive health. Why am I saying this? Because whatever be the effort with regard to reproductive health, we haven't spoken much about how do we control for sexually transmitted infections in men. We target women as the focus of contraceptive programs when we need to actually enhance male responsibility for contraception through a concerted effort. The unmet need for spacing may be low, but it is very high in younger age women, which tells you that power relations, which Vibhuti madam and Veena referred to, younger women have lesser access to a negotiating capacity even within marriage. And even though there is an unmet need for use of contraception, most health systems also do not target the young women in early stages of reproduction, either to delay, if they are unmarried and sexually active, to delay their risk of pregnancy, or even within marriage to postpone the first child. They are very less likely to be targeted, even if they have a felt need for it. Our policy focus is targeting fertility when the total fertility rate, even today you can hear, in many states, they're talking about population control. Our policy experts, in parliamentarians, quite a few are talking about need for population control and targeting certain subgroups within the population when the greatest declines have been seen in states like Rajasthan and Madhya Pradesh. Total fertility rate in many states is below replacement. There is an emphasis on maternity care, and there is regulation for surrogacy and IVF, but very limited attention to infertility, where it is a problem of reproductive failure. If we said reproductive justice and reproductive rights, we need to also focus on the ability for reproduction for people like transgender communities who also have a right to have children in whichever way they deem fit, either through facilitation of adoption. But most of our laws are within a heteronormative frame of reference. And that is another thing we need to talk about. And where are we now? Our health systems are hugely burdened with the pandemic and the maternity and maternal and child care burdens. ASHA workers are burdened, very poorly paid, and yet we celebrate them by awarding them in different. Yes, it is commendable that we recognize their work, but how much can we overburden them? If there are ASHA workers working for women's health, if we need to enhance, acceptance of other subgroups, we need to have other groups targeting men for sexual and reproductive health, groups working for transgender populations' health. Gender work, sexual and reproductive health work is work in silos. We work health systems, we work in sexual and reproductive health, we work in gender, we work in medical education, we work in silos. We fail to recognize that all of these are silos standing on a phenomenal intersectional inequity that represents society in India. We work as sexuals, and if we start with that, and we work in these various silos and expect men and women to achieve gender equality and education, sexual and reproductive health reforms, health sector reforms to meet the health needs of men and women and transgender communities. So have social and economic development, improvement in health infrastructure, contraceptive availability. We are working in those silos, and we need to reach target of gender equity. We will not be able to, because the gaps, the lack of an intersectional lens between these various things that we keep doing are going to allow men, women, and all people to fall within the gaps in these things. We need to reorient our policy for gender inclusive sexual and reproductive health. We are emphasizing on reduction in fertility. We need to focus on inclusive policies for men, women, and transgenders to achieve their reproductive goals. We are increasing choices for women, but we need to do that without increasing their contraceptive burdens by focusing on improving male responsibility. We need to include men in sexual and reproductive health programs, both as supportive partners and as targets of our program by, enhancing access to condoms. But I don't mean going back to targeted regimes, but also looking at men as people to whom we have to talk to, strengthening health system responsibility for bringing focus on men. This means we need to include transgenders and people who non-mainstream, sexual orientation as LGBTQs to walk into health systems to seek healthcare. If you talk to them now, you realize how disadvantaged they are with regard to anything, including access to patients for such a challenging situation as we have experienced during the pandemic. So we need to strengthen health systems to manage infertility beyond regulation of surrogacy and IVF. And these are some of the things we need to do, but not all of the things we need to do. I've been very restrictive in terms of my policy prescriptions because my focus has been on sexual and reproductive health alone. There is a lot more to be done by emphasizing on gender equity, but we need to recognize that that is the platform on which most of our inequity is, the platform on which all of our programs run. And therefore, bridging that calls for us to work in a manner that is integrated, inclusive, in order to achieve these goals that sexual and reproductive health is inclusive and gender inclusive in particular. Thank you.
Thank you, Professor Mala Ramanathan, for such an enlightening and in-depth analysis. There are some questions on the chat box, and I would like to read it out for them, ma'am.
Yes, can I start addressing this? Dr. Ms. Meenakshi Gopinath has asked, what is your opinion on increasing age at marriage of women to 21? It's, merely by increasing the age at marriage to 18, we didn't achieve much. Marriages continued to happen at various ages, and by having rules which are restrictive, we might only wind up penalizing women. On the other hand, working to, and also by not emphasizing on universal access to contraception regardless of marriage, we are also going to disadvantage those women. Whether the age at marriage is increased from 18 to 21, depends on how we target its achievement. if we are going to simply blame people for getting married below and restrict access to any, healthcare interventions for them, then they're going to be further disadvantaged, particularly women. We need mobilization to realize this. And in the meanwhile, we can't abandon those women. We need to emphasize on universal access to healthcare and reproductive healthcare, including, understanding of what is reproduction, starting from adolescent women, and ensuring universal access to literacy, education, and all of it. And how we move from, the ages of child marriage, we will automatically move to other groups. And the focus on spacing, the question from Sushrita is on focus on women's spacing. Now the government
Professor Mala, stop sharing so that we can have full view of yours.
Yes, just give me a minute. Yeah, is it okay?
Yeah.
There was a second question and now that has vanished.
Ma'am, should I read it out for you?
Yes, please. Can you? I can't find it.
Yes, ma'am, sure. Susrita Roy G is asking, thank you for pointing out that focus is on women for spacing methods. Now the government has introduced cost for condom and OCP. Do you think that this will affect the adoption of spacing, especially for male?
I think, unless this is based on my work in the grassroots level, people are struggling to access contraceptive commodities. That's near universal, particularly in the states of UP, Bihar, and such places. It is not that there is no felt need for contraception. They are struggling. And, there is a lot of exploitation also by local vendors when our system doesn't provide subsidized contraceptive commodities at local level. The condom box is not easily accessible. Mission Parivar Vikas emphasizes on that. Local vendors are stocking very expensive condoms. People are struggling to buy them. They are still buying them. We need to have, but on the other hand, people don't trust free commodities. So we need to have a sliding scale, but we need to find out the sensitivity of pricing before we price it and the extent to which we did it. And we need to have access to commodities for women, particularly when they can't afford it. So while we can price it, we also need to have an option available to ensure that people who need it but cannot afford it continue to have access to some of these commodities. So if we universalize, cost, it is going to fail us because a lot of people will not be able to buy. From what I understand, a sensitivity analysis, 15 rupees condoms are very difficult to buy. People were struggling to buy it on the basis of some work I've done in some states. So it is definitely going to be restrictive. Sushruta, I hope it helps you to answer. It answers your question.
Ma'am, there is one more question from Sunita Singh Ji. Okay. I will just read it out for you. What is your view on the two laws, ART and surrogacy law?
A special session on it.
You have to understand the ART and surrogacy laws emerged not as a response to infertility, but the gendered use of women's bodies through transnational arrangements, which resulted in adverse consequences for the women whose bodies were used in these transactions. It did not emerge from a reproductive rights discourse, while a lot of feminists are still struggling to induce it as within a rights framework. The outcome of all that has been a regulatory discourse rather than a rights discourse. We still need to keep arguing but that is where we stand. While on the one hand, one has to also look at the most disadvantaged. That law came because a lot of the women's bodies in transnational surrogacy, etc., whose bodies were getting used and commodified also, this was seen to restrict that. As a consequence, it has also restricted transgender rights, LGBTQ's rights, while it retains single women's reproductive freedoms to a modicum. It doesn't stretch it to, quote unquote, male bodies in this discourse. So there is a lot work to be done by all of us yet in terms of both advocacy and bringing in research to demonstrate its adverse consequences, to bring about changes in laws.
Ma'am, I think Professor Veena ji has raised her hand. So, ma'am, you can go ahead with the question.
No, I just wanted to bring to my experience as a medical officer at the postpartum center distributing condoms and this when I began my career for 2 years as soon as I finished my MBBS. And during this time, we used to cater to a lot of people from rural background. They used to come on market days and collect contraceptives for 3 months. Many of them, their husbands were aware, some of them were not, but they had decided after the first child, at least when they were breastfeeding, they need to take some contraception, and we used to revisit them regularly. So there was a time the government supply was Mala D and the market was Mala N. So when the Mala D was stopped for some reason or the other, we were not getting it. We went to the head of the department, we rallied with him, either you pay or you take money from us, you collect money, but make sure our people get Mala because they cannot lose trust in us suddenly. Till then, we keep thinking this is the most important thing for you to take if you want to do spacing. And suddenly we say government doesn't give, so it's okay, we can't do it and things like that. So thankfully, we were able to get for every person 6 to 7 months, and we managed to give it to our people till again the government supply resumed. Once there is a faith in the system, we need to retain it. Because it would be very wrong to us to say, okay, don't do it, buy it, because many of the husbands are not aware. Wives are taking, but wives are looking after their own reproductive health this way by spacing. Otherwise, this lady, one of them who told me her sister had 11 children and she died in the 11th labor. So she says, I don't want to go through that. So whether my husband knows or no, I don't care. I want to take it. So tomorrow, when you make it a compulsory that they have to buy it, who will have the money? If they don't have the money, does that mean that they can die in the 11th labor? It's somewhere leaving people high and dry. And I feel emotionally, it's a very wrong decision. Whoever makes a call, do not put themselves in the immersive way that what could happen in the best case scenario and the worst case scenario. They're only looking at the best outcome from economy point of view and not from a woman's point. And that is where I would not like contraceptive to be just over the counter. Thank you. That's it.
I can add a bit to this. There is a lot of field experience from various communities where women and Asha workers' burdens also, that once the same thing that Professor Veena is talking about, there is a trust and Antara is not locally available. Asha workers have to struggle to find out where it is available and facilitate women's, even commuting to the alternative healthcare center where it is available to ensure that they have contraception that of their choice for use. And this is happening in contexts where women negotiate contraception with their partners. The system is still talking about Sas Bahu Sammelans instead of enhancing and increasing access to contraceptives. And their discourse is, why do you need to talk to our mothers-in-law? We discuss with our partners and we are using contraception. We don't want others to know. And it is in that context that our systems are hidebound, our men and women have moved ahead. We need to be ready to change our policies to suit emerging needs. And we don't seem to be, emerging from a discourse of the, the post-millennium decade to this decade. We don't seem to have our ear to the ground to listen to the voices of these men and women. And that's where someone has asked. That's where someone asking this question that how do we bring women's voices? Even bringing Asha workers' voices to this discourse will help better public policy than all of us sitting and pontificating. I'm sorry to speak so rudely, but we need to find ways and means to bring those women and focus on their voices where they have their ear to the ground and make sure that becomes part of public policy discourse. Thank you for pointing
There
it
are
out.
4 questions for you, Dr. Mala. 4 questions are there.
Some-
I can't
Ma'am,
figure
and
out
couple
where I
more.
finished.
And you have around 7 to 8 questions actually, some on
Can
the
you please
chat
read
box
them
as
out
well.
and I'll go on answering if you don't mind.
Yes, sir,
At
I'll
one-
just try to shorten some
Yeah,
questions
okay.
for you, so it'll be
Okay.
easier. A person is asking, Alka Dhupkar ji, it's on IVF. She says that IVF is not as easy because it uses women's body as a means. So should adoption be promoted instead?
Absolutely. But we are living in a technological world which has enabled people to also think that, it is the right to reproduction does not necessarily, we celebrate, someone pointed out, celebrating motherhood and leaves out a host of other women who may not want motherhood by choice, leaves out other groups which may want motherhood through adoption. Those discourses are getting restricted due to the option for technological fixes. We need to enable adoption by choice, and we need to universalize that option, not through restrictive, culturally determined policies of who should adopt, but also enable, sexual minorities to be able to do that. And does that help?
Ma'am, another one is asked by Nandini Murli ji, who is asking that motherhood is usually glorified and women struggling with infertility are not being able to have access to services without being burdened by stigma, shame, and secrecy and silence. So how do we overcome such a scenario?
As part of a reproductive rights, we need to make infertility care a part of that. But also at the same time, learn not to celebrate motherhood. It's okay to have a child. It's okay to choose to not to have a child. The original understanding of reproductive health is the use of contraception. It was the choice to be free from even pregnancy if we want to be in freedom, sexual freedom from pregnancy, sexual rights, and reproductive rights. The discourse of sexuality is also weak there. And infertility, though we forgot, it's a forgotten agenda in reproductive rights. We need to bring it back without the secrecy and the shame. And we need to also emphasize on, male infertility, because infertility has become women's burden again in a gendered society. We need to build on all of that. The reproductive health agenda is so unfinished. There is so much more work to do, is all I can say.
Yes, ma'am. And ma'am, Sagar Shinde ji is asking how much of socio-cultural and religious norms are responsible for issues presented by all the resource persons, especially related to women and reproductive health.
You can take more questions together because one by one it is many. If you can.
Yes, I think Mr. Sagar ji has asked for like 3 questions in one go. So he is asking, what is the role of technology in improving the situation related to reproductive health and gender sensitivity? One is on technology, and another one is how can LGBTQ individuals be brought into nursing or frontline healthcare professions?
It's not going to be very easy, because into nursing care, bringing even men has been an uphill task. That's again gendered. We need to create spaces. We need a discourse. We need negotiation with, nursing councils and others. And we need to have, spaces even in medicine for as patients and as providers. We need to create these spaces for healthcare professionals, for, targeted interventions for various subgroups. They don't need to be provided by only people belonging to LGBTQ if we sensitize the whole community as a start. That is one. This other question is socio-economic improvement. That was the other question, right?
Yes, ma'am. The other one was on technology. How can
technology, this is not to say we need to stop access to technology, but we need to regulate its use or universalize its access as part of, a regulated choice for use, and not make it inequitable by privatizing certain services through prohibitive costs. No? And there are examples like the European, Netherlands and others do provide infertility care in a regulated manner. What we have not done is we've regulated IVF use and we've regulated surrogacy, but we have not regulated provision of infertility care, and not through public provisioning for those who cannot afford it.
Ma'am, Chandan Biswasji is asking, what is your opinion on God's instruction for not to use contraceptives and how to remove such superstition?
Pardon?
On believing on God's instruction for not using contraceptives and how to remove such superstition.
We have been working against it for aeons. We continue to persist to work, and we need to bridge those kind of discourses. It continues, but it's diminishing gradually. And if it continues to emerge, we need to continue to, have a discourse opposing it and facilitating, because see, not all discourses have universal acceptance. And that's where we need to recognize individual rights, not collective rights, and enable, freedom, reproductive freedom is not a collective freedom. If the woman there wants contraceptives, we need to respect that right. We need to enable that, even if it is, secretive. Are we?
Ma'am, I think we'll take the last question, that is on what is your view on bringing the concept of male ASHA workers?
I think that's really a felt need. I don't know what we will call them, ASHA or any other name, but there is a need for male workers in order to bridge an inclusive. That's another reason that a lot of the service provisioning in many parts of India is gendered, meaning our ASHA worker can only do so much. One is the excessive burden. Second is the restrictions which come from gender, of men not being able to ask a woman for condoms, which needs to be bridged. So I think there is a need to be having these male workers as part of our mission Parivar Vikas. I hope it happens. I've heard that it's likely to happen, but there is phenomenal resistance even from entrenched systems and bureaucracies. And let's see whether that gets bridged in certain states to provide, the way Mitanin did, an example for male ashas, whatever we call them. I don't know what they're going to be called. We need them for sure.
I think we had one more question, which I'm not finding it because they were writing in the chat box. Arjun, would you like to read it out, because I can't find them?
I will read it out. Yeah. Alka Dhupkarji is asking, I have a question. We see women are forced to go through IVF just because it exits with heavy marketing. Shouldn't be there strict regulation. IVF methods have become a norm. IVF is not easy as they use women's body as means. Shouldn't adoption be promoted instead? So 2-3 questions.
Yes, I answered that question.
Okay. So one is from Nandini Murli ma'am. So in a hetero patriarchal society that over glorifies motherhood, that it has even become institutionalized, how can we ensure the women struggling with infertility are able to access services without being burdened, stigma, shame?
Yeah, I answered that.
Yeah, answered that. Yeah.
So
Answer all questions.
I
think, yeah, we
is asking, raising hands.
So you will have to identify, because I can't see that.
No, you have answered. I have been tracking both. chat box as well as question box. You have answered all the questions.
Okay, Sushrita ji, you
There
are.
is Sushrita has raised hand. Yeah.
Yeah, I just wanted to add related to the topic on male ASHA workers. There was such a pilot, I wouldn't say pilot, across the state of Rajasthan called Janmangal Joda. But you know, it wasn't ever taken up by the state. And later, when I was working as in the government that time, and it was not even supported by the ministry when we were doing our PIP. So it is a tough ask, but I think advocacy of having more than just a male, whereas a couple who's into contraception, and then that can work better, even if it is voluntary or incentive based. Yeah. Thank you. This just adding.
Thank you
Right.
for adding that. Thank you.
Okay.
Okay.
Swati ma'am, would you like to add anything? You have been writing comments. Swati Rani ma'am? Okay.
Nothing from my side. Thank you.
Okay. So over to Professor Mala ma'am for your closing remarks. Yeah.
In summary, I'm grateful for all these questions because it helped to bridge the gap between public policy as it exists and the need for gender inclusive public policy as it ought to be. And talking about male workers, their engagement, the difficulties in accessing and regulating technology, the need for universal access without losing sight of the need for reaching contraceptive commodities to the most disadvantaged, the need for improving male responsibility with regard to reproductive health. And as it is emerging, we need to fan the growth, the embers of that, so that responsibility taking becomes near universal. And we can't wait for all these silos to, reach that gender equity. We need to bridge that through, appropriate policy, program efforts, and working with each other instead of in our silos, because the consequence of that is people fall within the crevices as sexual minorities, transgender groups, alternative, subgroups, people with, certain disadvantages as infertility. We need to bridge those gaps, so we need to work. And I'm glad that the group pointed out all these gaps and recognized them, so thank you.
Thank you, Professor Mala Ramanathan, for your extremely enlightening and in-depth presentation. Now, let's move ahead with the second session. I would like to invite our expert speaker, Professor Vibhuti Patel, who will be speaking on gender implications of the pandemic. Welcome, ma'am. The floor is yours.
Yeah. Good afternoon, friends. My presentation is on gender implications of the pandemic. So over last 2 years, there have been so many discourses on gender implications of pandemic by the women's groups, and the mainstream discourse has revolved around the crisis that the public health system faced. The waves of pandemic, first wave, second wave, and third wave, in that we had a different kind of challenges that we faced. We all know the whole economic history of pandemic in India. We have experience of Spanish flu way back in 1918 to 1919. We also had a series of epidemics like smallpox epidemics. When we were growing as children, we were hearing all the stories of horror stories of smallpox, and then plague epidemics. In fact, first modern teacher of India, Savitribai Phule, who was the first teacher of modern education, she died while nursing the patients of plague in the containment zone. We also have heard the history of tuberculosis in our country and the tuberculosis eradication program, and how the public health system coped up with these challenges during the colonial times and in the post-colonial times, but in none of those discourses we found the gender as an analytical category. For the first time in this pandemic, not only in India, but globally, we saw so many examinations and so many rapid assessment surveys done with the gender lens. We also, in the midst of major crisis, the staff sorted that the healthcare system faced, the corrupt forces, the license permit Raj, which was created during the lockdown, the gross violation of human rights, and rent-seeking behavior of the gatekeepers and doctors, both in the public sector as well as in the private sector. So that we saw, but what we saw that major implications, the dire consequences of pandemic on women-headed households, where the main responsibility was on the widows or single women, unmarried or divorced women. They are known as women-headed households, persons with disability, lonely senior citizens, pregnant women, homeless people, and by end of April, we saw there were millions of people who became homeless in the cities, mainly because they had no money to pay the rent, and they were informal sector workers. Reverse migration took place, and socially stigmatized transgender community, about which Dr. Veena Vaswani told us a lot, the kind of hardship that they had to face, and also the sex workers they had to face. Except for social work organizations like TISS or some NGOs, nobody even talked about what was happening to the prisoners and inmates in the overcrowded shelter homes and also prisons, and also makeshift tents in which they were surviving. How many of them died, how many of them became ill, what kind of treatment they got, we don't even have any data. On the whole, we saw that it was the daily wage workers, head loaders, construction workers, drivers, street vendors, domestic workers, security guards, small-scale manufacturing workers in recycling, scrape, and garment industries, barbers, like in one city of Mumbai only, we have more than 6,000 barbers who operate from the streets. All of them had nothing left due to unemployment and also the confinement over months together.
Ma'am, your presentation, are you sharing screen?
Acha, I have not shared the screen. Okay. Yeah, I will just.
And ma'am, you can also go a little slow.
Yeah, okay, I'll do that.
Yeah.
Oh, I thought I shared this.
Shall I share it?
No, I can share it. So yeah, here is the first slide.
Yeah. Ma'am, you can, starting say, you can go slow. Yes.
Yeah, okay. So first I told about the time period of the first, second, and third waves of the pandemic and the differential impact it had on the most vulnerable population, all those who face the intersectional vulnerabilities, and the kind of directives that the state had about social distancing, highly controversial term, because social distancing has a very painful historical legacy. In Indian context, it is caste system, and globally it is the apartheid, the kind of discrimination that the whites and the non-whites, discrimination perpetrated by the whites to the non-white population, and it also has a very painful legacy of slavery. So there was an uproar, and finally WHO sent a new directive that instead of social distancing, they should it should be replaced by body distancing. But still, most of the nation states, including in India, they kept on using the term of social distancing. Here also we saw double standards. It was the domestic workers or the Dalits or the sanitation workers who faced the major stigma and exclusion from whatever the daily survival needs that they needed. By March end, UN Women had already given the directive to all the 204 nation states, and they also gave a press release, and I quote, that COVID-19 pandemic is not just health issue. It is a profound shock to our societies and economies, and women are at the heart of the care and response efforts underway as frontline respondents, health professionals, community volunteers, transport and logistic managers, scientists, and more. Women are making critical contribution to address outbreak every day. Majority of caregivers at home and in our communities are also women. Additionally, they are at the risk of infection, loss of livelihood, and existing trends points to less access to sexual and reproductive health and the rise in domestic violence during the crisis. So this was a very important directive which UN Women gave, and that's why some response to the gender concerns was provided. The advisory, which was initially given about the social distancing, was later on changed to physical distancing, and these are the posters which were circulated globally by WHO. What we saw was that question of unpaid care burden on women that increased drastically, and data from all rapid assessment surveys also showed that women are more likely to see increase both in unpaid domestic and unpaid care work, and also they are more likely than men to say they are in charge of performing all three activities: unpaid childcare, unpaid adult care, unpaid care of the sick, and unpaid domestic work. Now, this, on the contrary, the rapid assessment studies of WHO, of UN Women also showed that men would share only fewer tasks. That means like shopping for the household or playing with children. No, these are the two tasks which were shared. The rest fell on women. Work from home and work at home. This directive during the pandemic, which most of the countries they asked their working women to work from home, they had to handle unpaid work like home chores, childcare, homeschooling, and elderly care, and that was acknowledged by the UN. If we see the healthcare providers, the last line workers of care work, in India we have 9 lakh public health workers, 10.3 lakh ASHA workers who have been applauded now by WHO. We have 27 lakhs Anganwadi workers who work in the Integrated Child Development Scheme. We had government school teachers who were assigned the task of distribution of PDS after the declaration was made that the people in poverty groups and people who had a BPL card would be provided free ration by the state during the pandemic. And that distribution of this ration was assigned to women teachers. We don't even have data because there are massive death toll of these teachers who also, while doing their work on duty, they were contaminated with coronavirus, and many of them died also. Women as healthcare providers make up 70% of the frontline healthcare workforce as doctors, nurses, ayabais, sanitary workers, Anganwadi teachers, Anganwadi workers, and ASHA workers, and they were more exposed to greater risk of infection. And you can see that most of them were not even provided personal protection equipments. They were using their handmade masks, and sometimes they were given even hand gloves. No, they were using. This scenario, many of you must be familiar, and these are the pictures taken by the citizens while reverse migration was happening. After all this trouble of walking for miles together and hundreds of miles of journey that they had to manage in a most difficult circumstances in the month of May, when they reached their destination also, they had to face biases and stigma. Many of the rural counterparts even refused to allow them in the villages. Here we see that even in this reverse migration, women faced more hardship. You can see in this truck, all men are at the corner and women are in the midst. Now, in the post-COVID period, these women are telling their horror stories of what happened when they traveled for miles together. They were away from their home and the safety for nearly 8 to 10 days. And we also saw so many deaths, so many illnesses, so many people suffering from dehydration and body injuries that we have been in. So in this context, the question of reproductive health became very important. There were pregnant women, roadside deliveries took place, maternal deaths took place, senior citizens were being carried by the young relatives, children were falling ill, they were carried by their parents. The persons with disability faced even more hardship at the time of reverse migration. On the way, they were robbed, cases of extortion, theft, sexual violence, child sexual abuse, trafficking took place. There were panic attacks, there were incidences of suicide. There were road accidents, train accidents, and trafficking of women and children happened also in a big way. So I think these are the kind of tragedies that they face. At the same time, there were also the efforts at social solidarity, massive documentation of how civil society organizations or individual citizens or NGOs or community-based organizations, they provided support. They also started the camp for the migrant workers, homeless people. Community kitchens were started. People, students and youth and people in the cities, they were contributing to make their life relatively easier. Migrant workers themselves, women themselves, were also contributing their free labor to make thousands of chapatis in the community center, and they were also helping in every way. They were also providing emotional and other support to each other in terms of care in the midst of those hazardous circumstances. Here, what is important to understand is that the way gender norms are defined in our society and what kind of work, unpaid care work that men and women in our country are doing. Most of the corporate world, they did not even take into cognizance this additional responsibility that women had to bear, whether they were middle class women or working class women, the unpaid care work. If you see the macro data provided by ILO or our own time use surveys, which show that women are involved more in urban women are giving 312 minutes per day for unpaid care work, while the urban man gives only 29 minutes. Rural women allocate 291 minutes for unpaid care work, while men do only 32 minutes of unpaid care work. These are the official statistics. Still, none of the companies, none of the employers, they say that they would give special leave to women in this circumstances when so many families after families, they were getting patients of the coronavirus, and public hospitals, private sector had already washed off its hands, hospitals were closed. It was only the weak public healthcare system which was overburdened with the patients, and finally state also provided the whole support system for home-based care and social isolation, which also increased women's burden because 24/7 all family members were in the home and they all had their own their demands. Students' online education, their children's online education had to be supervised. Cooking, cleaning, caring of elderly, caring of children, caring of sick people had to be done by women. Now, it is during the lockdown only we got this, for the first time in Indian history, we got this data from Ministry of Statistics and Program Implementation, MOSP it is called, that Indian women spend 299 minutes in a day for doing unpaid work, while Indian men spend 99 minutes. Now, so you can see the different type of activities. When it comes to employment and related activities, men's time is the blue bar is for men and red one is for women. So you can see that in most of the cases, men's time is more. But when it comes to unpaid domestic work, unpaid caregiving, unpaid volunteering, and this thing, it is women who are giving more time. And still, our economists and our newspapers were screaming that economy is closed. Actually, it is, that's what we would like to tell, that it was not closed, because everyone was cooking, cleaning, taking care of their loved ones. And it is not just valued by the economists because it is normally unpaid women's work. And the same type of devaluation of women's labor also extends to devaluation of women's health needs. So it is very important to understand these three, unpack these 3 R's. Redistribute, that means transform social norms. Start talking about sharing of housework. Housework or a care work is not only women's responsibility. Engage with men and boys. That is very important. Those who are into care work, make it more affordable and accessible. Care services are very important. The state has to provide this thing. That means you have to increase the budgetary allocation for the public health and for the care work. Recognize that the state and employer need to acknowledge the role of care work, important role. Without care work, overall larger economy cannot function. If you are talking about a $5 trillion economy, it is resting on the back of care work. Measure the time use. do the cost benefit analysis. If the educated woman or a scientist or a doctor or an architect or a teacher has to pull out from the workforce, that's what has happened. The women have been thrown out of workforce. Even in the post-pandemic period, they have not been taken back. So you are losing a talent pool. Nation is losing. Even World Economic Forum and all think tanks are saying that India is losing a lot, because you have women who are degree holders who are highly qualified, but it doesn't translate into employment and they are not able to contribute to the economy. So raising awareness, building capacity, and creating a supportive environment for the caregivers is very important. And third very important aspect is to reduce the care work, that is labor and time-saving technologies. They need to be brought in to remove the drudgery part of the care work. Gender responsive infrastructure we need to create, and also high quality public services are very important. And here the public health system also needs, which are located only at the most in the cities and district places, but in the interior parts of the country, public health system is hardly existing. Now, women's struggles for the maternity health services, Dr. Mala has told us a lot. And what we saw during the pandemic is that women delivered babies on the road, in the train, in the rickshaw, in the front gate, front of the hospital gates. That scenario in Agra that we saw. Even in Bombay, we were getting panic calls on the helpline about pregnant women in labor not being allowed by the gatekeepers, when inside the maternity ward, the beds were empty, but the gatekeepers would not allow them in. And there was also, they would ask for 2 lakhs rupees per bed. Those incidences were also reported. Asha workers, police women, people on the road, and they were the ones who helped women in labor. 24 women delivered babies in the Shramik Express when the government provided free travel to the migrant workers to reach back to the native place. So at that time, we saw the delivery taking place in the running train. Denial by the hospital to admit women in labor, that happened in a big way, because all the services were geared towards management of COVID. And all other all other services, whether it was a comorbidity or the reproductive health services, were not declared as essential services. And as a result, miscarriages, unsafe deliveries, stillborn babies, neonatal deaths, maternal mortality, maternal morbidity, which is still now a major challenge that we are facing, and the self-delivered babies that we saw, even the photographs of the women who delivered and cleaned their placenta themselves, child mortality that took place in a big way. And that's why there was a demand by the women's groups to start an urgent helplines totally dedicated to the reproductive health needs of women. We also saw that the various reproductive health concerns of women under the lockdown that were highlighted, which needed the urgent attention. One was the menstrual hygiene and sanitary pads. Immediately after declaration of lockdown, the total lockdown, I think it was the women's groups and the community-based organization, Janaswastya Abhiyan, Medical Friends Circle, they raised this issue of making sanitary pads available, especially in the context of Corona, which demanded that you need to regularly wash your hands. So water was needed in a great this thing, and people in the basti, people in the communities, they had a tremendous water shortage in a normal times also. So sanitary pads were very important for menstrual hygiene. How to ensure safe, timely, and quality maternal health care at the community level became a major challenge. And discontinuation of antenatal care as a result of lockdown, and I think even the ICDS center vaccination program, triple polio, and as per the national immunization schedule, all of them became the casualty. There were barriers in accessing institutional facility for delivery care, and also for many other comorbidities that people suffered. Neglected neonatal care are immediate issue, and they are being reported at the community level. And now also we see that in many places, still the system has not been put in place. Pregnant women were walking on a highway for thousands of miles to reach their native place. Women delivered babies in the roadside and outside the hospital gates. That happened. And according to the Ministry of Health data in June 2020, what we saw was that they had data of only 24% of newborn babies and data of only 17% of the newborn babies and 24% of pregnant women. So you can imagine the data loss that we have. We don't have current statistics about this kind of reproductive health issues that we are facing. And in most of the 76% of pregnant women and 83% of newborn children are nowhere in the data bank. And what happened to these people, whether they faced any problem, health problem, did they die, were they vaccinated, did they deliver their babies in the homes, or did they get medical care on time? We don't have any data. The case of infants is even scarier because they were what happened to the immunization program? Did they get their vaccination, or how many of them have survived? We don't even have data for that period. Now, mental health concerns. Now, you know that for the first time in Indian Union budget, some 760 crores are allocated for addressing the mental health concerns for the first time in the budget that has happened, and the special emphasis was made by the finance minister. So the kind of mental health problems and challenges that we faced during the pandemic, there was a worry, stress, tension, anxiety, numbness, sadness, the switching from living to surviving, so that kind of a existential status that people face. There were confusion about in the mental status, food and eating challenges and difficulties people that children or adolescent or pregnant women or people in general faced. There was a resurgence of compulsive and addictive behavior. People were there 24/7 at home. There was a no mobility. They were confined at one particular place. So obsessive and intrusive thoughts and memories of fear that they faced. Generalized fear, anxiety, panic, overwhelm, and also depression, dissociation, shutdown, freeze. These kind of traits which the psychologists are talking about, they were found in great number. Those who are running the helplines, such as iCall or other emergency helpline or the distress call helpline, they were saying that there was a very strong feeling of hopelessness, feeling of abandonment, loneliness, isolation, sense of loss of control or powerlessness that they felt, anxiety around money, shelter, food, other survivors, those who had a petty business, they lost their business. There was a massive unemployment. 92% of the informal sectors, they lost all their wherewithal. The lower middle class, they call them missing middle because they were not recipient of the government's support system, or the schemes were not even directed to them. They also faced the trauma. The past traumas were being triggered, they were activated, people were reliving the painful experiences of the past. The health anxiety heightened during the pandemic, and and even in cases of comorbidities such as diabetes or heart problem or hypertension. Feeling of like existing in a chronic needs are being ignored. That was the feeling which people were getting. Thoughts and feelings about death and dying. We're seeing so many, most of the newspapers or the media or the messages about death or illnesses that also created the grief, situation of perpetual grief, feeling of anger, irritation, frustration, caring for everyone to one's own detriment. That happened more so in case of women. Feeling of getting exhausted, fatigued, unmotivated, and lethargic, that happened. And hyper focus, surges of energy, and also keep doing to distract, so continuously keeping yourself busy to distract your attention from the painful reality that happened. What we saw in the rural areas and in the tribal areas of mass starvation, loss which was faced by the tribal women. 11% of women population in our country is of a tribal people who live in the forest and in the hinterlands, and they lost their livelihood. Whatever they had collected in the month of March, that could not be sold. That's only one time in a year where they get their money. And they were women who farmers and forest dwellers, they are not even recognized as workers in the official list. So women-headed households, they faced major hardship because they were deprived of whether it was 151 types of Garib Kalyan Yojana or the Atmanirbhar Bharat Yojana. They were not even netted, they were not even covered by these yojanas. And even MG Narega, which in a pre-pandemic period where you saw 60-65% women, especially in the 4 southern states and in Western India, massive number of women. The women were always in majority in the Narega scheme. But once the reverse migration happened, even the local authorities, the district magistrate's office or Panchayati Raj institution would also tell that when so many men are unemployed, they are standing in the queue. So why should women be there? So the men's entitlement towards MG Narega, that got more emphasized, and women were the ones who were neglected. And there was such a big demand for MG Narega job that the funds allocated 1,11,000 crores, which were allocated in 2021 budget, also got exhausted within 3-4 months in so many states. So women suffered a lot. Gender-based violence, which was declared as a shadow pandemic by the UN Women, that had so many ramifications. We saw increased incidences of child marriages, forced marriages, child labor, because children were thrown out of school. 1 crore girl and 3 crore boys in our school system, they were thrown out. We can't call them dropped out because these children did not have any choice, because there was no internet connectivity. They did not have smartphone. They lost out from the online, and the online education was became the demand of the day during the pandemic. Domestic violence, cases of domestic violence, we have 2 experts who will be talking about it in the next lecture. They have done extensive work on domestic violence. Sex-selective abortions took place. UNFPA data says that because the PCPNDT Act, Preconception and Prenatal Diagnostic Act, was also freezed during the pandemic, that so many cases of sex-selective abortions have taken place. We don't have a data because 2021 data we don't have about child sex ratio, because the census was not conducted. We have to depend only on the NFHS data. Incidences of sexual violence, child sexual abuse. In fact, the helpline by the National Commission for Women received 375,000 distress calls of children, out of which 25% distress calls were from the adolescent girls. They had contacted, they managed to access the helpline in the midst of they being soul trafficked, or they faced cyber crimes, or they were forced into marriage. They faced trolling and cyber stalking. So we saw that child helpline 1098 and women helpline, which is a jurisdiction of all India jurisdiction, it has 181. They were inundated with the distress calls. Violence against women escalated due to social isolation during the lockdown. Women's groups like Sehat, where Dr. Padma Devastali, Sangeeta Dege, they will tell us about the kind of support system that the women's organizations provided. This kind of mobile numbers were made to public. They were circulated online as well as in the newspapers. And what emerged in this whole tragedy was that there was a need for a better communication, dialogue between state and non-state actors, use of information technology in a very, very judicious and pro-people way, providing relief and resources, and also appropriate policy to combat the ill effects of pandemic. That was very important. The major concerns with the people's organizations they provided was that ensure the delivery of reproductive health services, sanitary kits, menstruation health supplies, maternal health care, availability of curfew passes to the family members of pregnant women were needed, balanced diet for pregnant and lactating mothers at the camps and communities, because ICDS centers were closed during the pandemic, provision for 90 days of wages to all pregnant women in 3rd trimester and lactating women with infant aged less than 6 months. So that was also a demand. And the services of women helpline, short stay home, one-stop crisis center, child helpline, they were needed in all states all over the country, which were found very inadequate during the pandemic. Directory of support services for women-headed households, persons with disability, transgender community was very much needed, mainly to provide them additional support and the specific need-based support. Combating increased child marriages, human trafficking, and gender-based violence under pandemic, that becomes a very important concern. And learning also of the pandemic, so that now we have to live with the pandemic. And yesterday's statements, they say that pandemics are going to be endemic. And that's why we need to be prepared in future also. When we face such health emergency or any form of disaster, we need to take into consideration these aspects. Women as healthcare seekers, their special needs, they have to be taken care of. We have to maintain adequate stock of menstrual hygiene product at healthcare and community facilities, train medical staff and frontline social workers to recognize signs of domestic violence, provide appropriate resources and services, and also we have to provide more, the private sector also had to be made conscious of these issues. It is not only the responsibility of public healthcare system, but the private, because in India, 85% of services are provided by the private healthcare system. Question of providing how to make the targeted intervention and need assessment is very important. Most of the women's organizations and NGOs, community-based NGOs, they did that. What were the special needs of women-headed households, or person with disability, or a woman who was pregnant, or those who had a certain type of tuberculosis or HIV/AIDS, or their specific needs were listed, and accordingly the support system was provided. So reduction of social inequality in care services is an overarching concern that we have, and whatever macro policies that we come up, we need to see to it that gender exclusion is avoided, and we have to ensure justice, equity, and dignity in gender relations and combating the pandemic. Along with that, we also need to encourage equitable sharing of domestic tasks in explicit terms through allowances for time off and compensation to the workers. So even the employers' organization had to be sensitized, ensure increased access to sanitation and emergency shelter spaces to unhoused people. Only Kerala provided this kind of hostel to the migrant workers. So I think it is possible. If one state can do, why not others? Implement protocol and train authorities on recognizing and engaging vulnerable populations, particularly where new laws are being enforced. And consultations of government bodies with civil society organizations are a must for implementing legislation and policy, and for guaranteeing equal access to information, public health education, and resources, not only in English, but in all the regional languages. And so the safety and personal protection for all the healthcare workers, water and sanitation to be made accessible, universally accessible to the community, creation of a dedicated helplines for the migrant workers or for the pregnant women, for the people undergoing mental distress, they are very important, and safe transport for the women workers, because mobility becomes a major impending force. Gender responsive participatory budgeting as a public economics, very important policy measure that we have. Gender disaggregated benefits, incidence analysis of public expenditure, that whatever kind of measures that we have taken in the area of public health or in the health delivery, who are the beneficiaries and how can we improve it? That's very important. Then gender disaggregates the key issues in gender responsive budgeting. They are health, education, skill building, and combating gender-based violence, and in enhancing women's participation in the decision-making body. Currently also, I think Dr. Swati Rane always raises this issue, that do women have, the doctors or nurses or scientists, have any say in the decision-making bodies regarding the public health emergency? That is very important concern. Gender-based violence had to be combated. We have to be more aware. We have to sensitize the system. All the healthcare system has to be more responsive to deal with the gender-based violence. Implementation of PCPNDT Act, and also protection of women from domestic violence act. More awareness is required about the service provider's role. Social security programs for shelter, pension scheme development, investment in transgender community and persons with disability. I think there so many of them are there. The schemes are there on paper. Money is parked in the ministry and departments, but it doesn't reach the people who are actually in need. If we see globally, if we do the global comparison of what has been the India's response to the COVID management, you can see that India has allocated only 7% of the GDP for the COVID management as compared to so many other countries in whether even countries like in developing countries of Latin America, even industrialized countries have allocated more. But if we see, even Brazil has 12% of GDP allocated, while India's contribution is very less. When it comes to the allocation of hospital beds and physicians for the population, India has the lowest record. That itself shows that how public health system, the government expenditure on the public health system and public healthcare facilities is minimal. It is less than 1% of GDP, and as a result, there is tremendous shortage that common people who are struggling to survive are facing. If we see the vaccine inequality, IMPRI also had a special panel discussion on vaccine inequality. Here too, we see that vaccine inequality is a major issue that globally so many countries are facing. There are African countries where you have less than 2% of population which is vaccinated. India comes somewhere in the middle. Okay, so that too, that also we need to address. Potential unintended consequences of COVID-19 vaccine policies. Also now a lot has been discussed about that by the behavioral psychologists, by the political and legal effects that it is going to create, and also the socioeconomic implications that it will have, and the integrity of science and public health in terms of erosion of key principles of public health ethics, that public health is meant for the social good, maximum benefit for maximum number of people. That has been the philosophy of public health. Where are we in this? And the erosion of trust in regulatory oversights because of the gross violation of all the health ethical standards, as well as the gross violation of human rights that we have seen. So India ranked 131st among 189 countries in the Human Development Index. When it comes to World Social Protection Report, India's record is only 2.5% of the average that India has allocated for health and the social protection, only 1.4% of GDP, and has been allocated. Oxfam report titled Inequality Kills showed that 84% of Indian households reported reduced income. PFLS, Periodic Labor Force Survey, 2020 showed 68% of people earn less than 12,000 per month in India. Inflation is galloping in the post-COVID period. State of Working India report also showed that for sustainable employment, and the Azim Premji University study shows that 82% of men and 92% of women earn less than 10,000 per month, and the country has the highest rate of unemployment in 20 years. In last 3-4 days, politicians and newspapers are discussing the extremely mind-boggling issue of urban unemployment, and that's why they have demanded the kind of scheme we have, Narega, we should have one for urban areas also. Global Hunger Index report 2021 shows that India is a middle income country with widespread hunger, and India ranked 101 first out of 116 countries in the Global Hunger Index. And in the ranking of United Nations Sustainable Development Goal, India ranked 121st out of 169 countries. Overall, India's score was low on SDG, that is SDG 1 on no poverty, SDG 2 on zero hunger, SDG 4 on quality education, SDG 5 on gender equality, and SDG 10 on reduced inequality. So it is what we need is combating pandemic and the after effects of pandemic with a human face. And for that, fiscal expansion is very important. Strengthening the local communities is very important. Care and care work and food production, they need to be more interventions that state has to make it more accessible. And also the pandemic profiteers, such as big technology and e-commerce sectors who have benefited exponentially from the COVID-19 crisis, there should be special tax. Some of the Latin American countries have done that. Investment in care infrastructure and services such as health, housing, water, sanitation, ensuring decent labor condition is important. Digital justice is need of a day because digital divides keeps people excluded from all the benefits of health benefits, of educational benefits, and also the benefits of better quality of life. Community organizations and social justice movements can guide economic policy so that it finally works in the service of society and environment. We need to create new helplines of missing people. Now people are saying that they are neither in city nor in their native place. Where are they? So there is a need for missing people's helpline. So many community-based organizations have voiced their concern about missing people, and citizens facing mental health challenges, that we need helpline for them. With compassion and understanding of multiple marginalizations, so much can be done to shift the margin to the center stage. I would like to conclude with once again emphasizing that reduction of socioeconomic inequality through engendered public economic policy, gender responsive participatory budgeting, and universal basic income. Even the private sector think tanks are also recommending universal basic think tank. Several countries have also implemented it. India has it is much behind this kind of progressive measures. Universal access to healthcare services and 6% of GDP for public health budget. In fact, WHO had requested 10% of GDP should have gone for public health budget. Currently, India's contribution is only less than 1% of the GDP. Protection services to deal with violence against women and children, domestic violence, intimate partner violence in the context of lockdown. In future also, whenever such social isolation the condition takes place, we need to provide this safety net. A safe transport for the workers, with limited resources, NGOs, CBOs, CSOs, women's rights groups have done great work with courage of conviction. I think it makes it imperative that the government organizations have a dialogue with the non-government organizations. There are so many learnings that you have. Along with human rights organizations, the state needs to adopt human rights-oriented protocols with regard to people in administrative migration centers, quarantine centers, confinement camps, people with disabilities in the institutions, psychiatric facilities, prisoners who are at high risk of any kind of contagion, whether it's a COVID-19 or now new variations that we are getting. Maharashtra has already reported over 1,000 cases in the current wave in the confinement condition. These are some of the references that I have used. All of them were conducted, researches were conducted during the pandemic. Mostly they are based on the telephonic interviews and also rapid assessment service done by the community-based organizations providing support to the communities to combat pandemic.
Thank you, ma'am, for enlightening us with such a deeply researched presentation on pertinent issue. There are some questions on the chat box. Dr. Swati Rane Ji is asking, mental health is still seen through biomedical model, which needs evolution. Mental health needs to be brought in segments like schools, old age, youngsters, women professional. What's your take on this, madam?
So yes, Dr. Swati Rane, I fully endorse your statement that mental health needs to be discussed, and community-based mental health interventions are far more effective than the biomedical approach. And that's why for the first time, like at least government is acknowledging that there is a major challenge and we are facing a tremendous challenge in terms of mental health conditions of people. And that's why I look, but now we have to see to it, the community organizations and the state governments and the subnational budgets also need to give this a priority. Otherwise, money will remain unutilized. We have experience of Nirbhaya Fund. Right from 2013, 1,000 crores are allocated. But are these funds, are they used for addressing the question of gender-based violence, except for CCTV cameras? What are the other major interventions which are made by the state? So money remains unutilized. So we need to see to it that this allocated funds by this union government is used for creating a community-based support services to address the mental health concerns. Yes.
Ma'am, and Dr. Swati is again asking, what is the way for girl children who are kept away from school because their parents don't have money to pay fee, and how to address this issue?
Yeah. So I think that now the government has, for the first time, the directive has gone to all the schools to identify how many schools, how many children have stopped coming to school. I think there was a time in April, the college in which I am in the management, only 25% girls had paid fees. Okay, that was a major thing. So now what the new education policy, national education policy says that public philanthropic model, public-private partnership, instead they are saying public philanthropic partnership that needs to be done, and you have to, each educational institution has to create its own corpus to support the services, to support the students who are facing the economic challenges and who are forced out of school. But I think that is not a solution. I think state needs to take up, and I think it is very sad that current union budget, 99% of the budgetary allocation has gone to capex, capital expenditure. Only 1% has come to social sector. In that, you have to take care of education, health, water, sanitation, and skilling. All that comes only in that 1%. So I think we have to ask for more support this thing, because the privatization of education is not a solution. In fact, it is creating major crisis. But currently, what they are doing is only estimating what is the percentage of children who are out of school, because you know that in last 1 year, the percentage of child labor has increased. Those children who are out of school, they are either into child labor. A lot of trafficking has also taken place, interstate trafficking, because child labor is the cheapest labor. So that has happened. But the state response is very, very demoralizing.
Ma'am, another question is on nursing profession, and Dr. Swati is asking, there are graduate master courses in mental health and community, but it's not included in the platform of public health system. So how do we make them inclusive?
Yeah, I think that is the role, and that's why we have this kind to create that kind of mindset, and also sensitize the public health professionals to take mental health issue, because see, there is a major problem is a stigma for the mental health concerns, no? So that people don't even talk about it, they hide it. So it's very important to bring the mental health discourse center stage, and then only we can we have to make the healthcare professionals more responsive to the mental health challenges that we are facing. You can't leave it just to some mental health hospitals. It has to be integrated in the healthcare facilities, and I think that's why community-based and also the decentralized mental health services become very important over and above helplines. But helplines are only just one aspect of it. What we need is a direct intervention, massive input in terms of counseling and hand-holding of a person facing mental health challenges. They have a major role to play, including the Nurses Association nurses have a major role to play. Yeah. Yeah. So Dr. Swati has raised hand. Can you unmute so that she can speak? Yeah.
Good afternoon, ma'am, and good afternoon to IMPRI team. Thank you for giving us this platform and the excellent course which is going on. I just want to ask you all that today, because of privatization in education, we don't have any any teachers associations or teachers unions, and that is one of the reason I feel that we don't see them coming, their voices coming in the system. So can we also in this course think along those lines as how can we bring some interventions with all of us who are interested in this gender courses in the system? How can we stir the system together to bring some change? That is my question to all of you. Thanks.
Dr. Swati Rane, we have a very strong teachers union, but doctors are not there. So medical colleges are anything for which the new, the different way of establishing dialogue with them can be done. And our next experts, next lecture by the two experts, Dr. Padma Devastali and Dr. Sangeeta Rege, I think that will throw light on that how they are engendering medical education and sensitizing the doctors to gender questions and mental health issues. Yeah.
Thank you, ma'am. Thank you so much.
I think with this, we have ended Professor Vibhuti Patel's presentation. Thank you, ma'am, once again for your presentation and addressing all the questions from the participants. So before we move on to the next session and the next expert, I would like to make a small announcement that is related to the course materials. Our experts have provided with background readings for your kind perusal and references, which is already shared in your respective emails. Now moving on to the next session, we have our distinguished experts, Dr. Padma Bhate Diosthali and Ms. Sangeeta Rege. Their topic for presentation is Gender Mainstreaming in Medical Education Beyond Stereotyping. Dr. Padma Bhate Diosthali is Program Director at Creating Resources for Empowerment in Action, and Ms. Sangeeta Rege is the Coordinator at Center for Inquiry into Health and Allied Themes, Mumbai. So with this brief introduction, I would like to invite our experts and please give your presentation. The floor is yours. Thank you.
Hi, Dr. Sauravi. I think the timing was kept as 5 p.m. For Padma because she is conducting a session elsewhere.
Okay, so
And
you can start.
So it's a little different. Vibhuti, the way we had planned it was Padma would do the gaps in the existing medical education, followed by a short film.
Okay.
And then I was looking at presenting evidence from an action research and where are we now. So if I start, it's kind of woven like that. What do we do? Can you give me 2 minutes and I'll connect with her and check with her? Otherwise, then I can do mine and we can go.
Sure, ma'am. Yes, ma'am.
Let's
do that. Yes,
Thank you. Just give me 2 minutes.
We had kept time for a break, but we did not.
No problem. Sure. I'll just get back
That's
to you.
why I hurried because I have my watch in front of me.
Okay.
So
give me 5 minutes, Vibhuti. I'll just speak with.
Meanwhile, Vibhuti, would you like to wrap your presentation?
Yeah, I have not. Yeah, correct. Yeah. So I would like to. Where is it? So I think the learnings of these 2 years of pandemic is that why gender awareness and gender responsiveness is extremely important when we face any kind of disaster, whether it is a man-made disaster, health disaster, or any kind of major problem that we face, social transformation that happens. So it's very important to see it from the gender lens. And even when we talk about gender, we need to be very sensitive to the intersectional marginalities. Once we acknowledge this kind of intersectional marginalities and intersectional vulnerabilities, we will be able to move towards intersectional justice. And I think for that justice, it is very important to connect the health issues with the overall systemic issues. What are the social determinants of health? What are the institutional constraints that we are facing? How do we link our work with the policies which are happening at the micro level? So what the local, wherever you are working in the hospital or in that area, and how the state government's policies, macro policies, and the overall global policies of the health care industry is operating, it becomes very important. So isolationist approach in thinking is not advisable. It is not in any way benefit. So this whole think about this only super specialization and hierarchization of knowledge that we are experiencing among the super specialists, I think we need to get out of our silos and we need to have interdisciplinary approach. We need to understand from the sociologists, social theories, psychologists, geographers, health professionals, and those who are active in the political bodies and governance structures. I think unless we have this kind of a dialogue, we are not, we are not able to address the complex issues like a pandemic, which completely jeopardizes not only the health of a person or individual or a community, but also the economy, your sources of survival, your livelihood, the kind of human miseries that come up as a result of complete dislocation of the normal life and the so-called new normal. How can we make the new normal more just, more inclusive, more accessible, all the facilities and the services of the society accessible to the people? I think that is the direction in which, if we want to move, then we need to have this kind of gendered social determinants of health we need to understand, and then come up with the solution and to come collectively. So interdisciplinary understanding of any mega event, mega disaster, whether it's a pandemic or epidemic, that is very, very important for the medical fraternity and all the citizens at large. Thank you.
Thank you, ma'am. I think for our last presentation, we would start right at 5 o'clock.
No,
So
no,
we
it's there. She's there, Dr. Padma Devasthi. She's there.
Yes,
They can
yes.
start. They can get more time. Yeah,
Okay, fine. So Padma, ma'am.
she's there. Yeah.
Yes, hi, good afternoon.
Okay, so would you like to start with your presentation?
Sure. Thank you.
Okay, please go ahead.
Yeah.
Thank you, ma'am.
Good afternoon, everyone. And thank you very much for this opportunity, Vibhuti and Dr. Vaswani, for inviting us. Sangeeta and I have planned this session in a way by which we will take you through the approach that has been taken by an organization called Sehat, which is based in Mumbai. We'll provide all the website and other addresses. And to also look at what has been the impact of integrating gender in medical education. I was happy to have attended Dr. Mala's presentation today afternoon, and we hope to build on what she spoke about reproductive health and some of the gaps that exist in medical education. I hope my slides are visible.
Yes, please go ahead.
Thank you. So this is a kind of experience from the field of having worked together with medical colleges and the perspective, the approach that we have taken and been able to make a dent in bringing gender and integrating that into medical schools in India. If you look at the international obligations, you will remember that Dr. Mala also spoke in her presentation about the Icpd 94, as well as the 4th World Conference on Women. Both these conferences, international conferences, clearly articulated and stated that gender-based inequalities are crucial determinants of health. So this was way back in the 90s. The WHO, the World Health Organization, adopted a gender policy only in 2002. And there was a consensus that by then, that gender and human rights perspective must be integrated into medical education. So this is way back in 2002 that there was a clear policy, and this policy mandated that all countries must develop and implement courses on gender. There needs to be curriculum development and tools developed for measuring impact of gender integration. There should be capacity building of faculty of medical schools, and also there should be an advocacy for policy change pertaining to the curriculum of health professionals. So this is way back, and this is a, if you look at this 2002 report, it's a documentation of various country experiences at that time for integrating gender in medical education. If we move ahead, so what have been the global experiences as far as integrating gender in medical education is concerned? We see that gender has been integrated into undergrad medical teaching. So there are various examples from various countries, mostly high income, but if you look at the screen, you will see that it's in the USA, Australia, Europe, also Philippines. If you look at what the content has been, it's really been a women's health specialty, or there's been an additional course around gender and health or around domestic violence. So these are different varied ways in which gender has been integrated in undergrad medical schools. There's also been master in public health programs, which kind of center stages gender, both in the US, India, Nepal, and also China and Turkey have actually integrated gender in their sexuality education. In nursing education also, there has been some integration of gender. And in India, it's this program that we are going to talk about. If you look at these global initiatives, what you will find is that they have integrated gender either as additional classes or additional courses. So as you all as participants would recognize that what happens when you do that is that people have to sign up for these courses. So it's not something that comes to you as part of your regular medical, lessons or classes. So it's a special class that you sign up for. Mostly the content has been around looking at integrating domestic violence issues into medicine and nursing curriculum. Very few efforts have tried to integrate an intersectional perspective. Where if you come to India, there has been a review of medical curriculum, and there has been critiques of the fact that that medical education in India is very biomedical. It has very limited content on social determinants. There's also been a review done of medical textbooks way back in 2006 to really look at what is the kind of content of medical textbooks from a gender perspective. And it's a critical review. The review brought out that most of the medical textbooks are extremely gender insensitive and gender blind. So there have been these gaps which have been identified as far as medical curriculum is concerned. Sehat's past work with health systems and training of health providers also brought out that the medical colleges don't really teach how to respond to gender-based violence. There's a lot of victim blaming towards survivors of rape as well as domestic violence. There are also problematic attitudes towards abortion. So the fact that abortion is morally wrong, or this insistence that the husband of the signature of the spouse must be sought. And this is also taught in medical textbooks. So it's not just practice, but it's also being taught in the latest editions of medical textbooks, that for female sterilization as well as for abortion, the consent of the spouse. And many of you would know that the abortion law does not expect or does not ask for any such signature, but it's there both in medical textbooks as well as in practice. There's a lot of judgmental attitude towards students, among students and educators towards single women who are coming for abortion. So that attitude exists for single women accessing any kind of sexual and reproductive health services. So as if sexual reproductive health services are only for married women. That's how the entire medicine is taught, and that's the understanding as far as sexual and reproductive health is concerned. Having said that, even when you look at women with disabilities, there are additional barriers that they face when they are seeking abortion. So one is that the healthcare facilities are often not accessible. The information around abortion may not be accessible in a language and way in which they can understand. There's complete insensitivity of healthcare providers, and there's an overall infantilization and invisibilization of women with disabilities by health providers and in medical textbooks also. So the approach in Maharashtra it's been a collaborative effort. So Sehat Research Institution, the Directorate of Medical Education, and the MUHS, which is the Maharashtra University of Health Sciences, came together. And the approach and the way in which this was laid out was to really seek partnership. So it was not something that an NGO just came and brought in and said that this is how bad your, the whole medical teaching is, and this is how you should change it. But it was not limited. Of course, the critique was there, and the critique had to be taken to these different groups. But the approach was to foster partnership and also identify opportunities and work together to see how change can actually be brought in. And first effort was made to really understand perspectives of teachers, and I will come back, I will allude to that in my next slide. So the team carried out a situational analysis where they spoke to almost 60 plus medical professors in Maharashtra to really understand how do they understand gender. So, what is their perspective around it? Do they think it's relevant? So that was carried out. That was followed by capacity building of medical educators. And then along with them, the MUHS curriculum of undergrad medical schools was reviewed. Gaps in gender were identified, and then content was developed together, which was published as gender integrated modules. They are all available on Sehat's website. And these modules were made in a manner that any medical educator could pick up the lesson and teach that lesson with a gender perspective. So the situational analysis that was carried out with over 60 plus medical professors across Maharashtra, what it really brought out, and we were quite surprised with the kind of responses we got. And this study was done in 2014, so it's not a very old study. So this is perceptions and understanding about medical educators about gender. So it was understood variably. So some said that it's a demographic category. Some said gender is health issues which are related to women. Some said this was in 2014 post Nirbhaya. So there was this whole recognition about violence against women, post the Delhi campaign, the nationwide campaign after the Delhi incident. So a lot of people associated gender as increased violence against women. There was this feeling that gender means increased presence of women in workforce. Many said that more women in the medical schools is what gender means. Most of them actually said that gender is irrelevant to MBBS. So there's nothing really important, not something that we need to look into. There were also several biases that were reported. So medical educators believe that sexual harassment is an outcome of increased women's work participation. So because there are more women, there is at the workplace, therefore there is sexual harassment at workplace. There was a lot of paternalistic attitude towards female students in medical schools. There were also some very discipline-specific biases that came up. And some of the psychiatrists said that women reported more somatic complaints than men. And therefore, this whole presence of intentional hysterical syndrome is much more in women because of this distinction. Gynecologists felt that second trimester abortion seeking women are all involved in sex selection. And they reported that they had worked out their own way of finding out the truth. And they said that if a woman refuses to go in for sterilization after a second pregnancy, then that means that she has actually undergone, she still wants to have, a daughter, and that's why she's refusing to go in for sterilization after her second pregnancy. Medicine experts believe that women in high-risk groups contracted communicable disease. So that was something that emerged. Also, there were other stereotypes that emerged. women seek healthcare for minor complaints, whereas men seek healthcare only when there's a significant concern. Women have poor pain threshold as compared to men. So these were some of the biases, stereotypes that emerged through this study done in Maharashtra in 2014. These were professors from the medical colleges which had been included as part of this initiative, we were able to take it back to the colleges and also help them recognize and they couldn't refuse it. So we were not taking evidence from elsewhere. It was from their own medical colleges, and these were the perspectives and perceptions from their own colleagues. So there was this entire effort made to build capacities of medical educators. And now the next couple of slides, I'm going to just allude to the kind of content that has been developed. So when it comes to sex, gender, and gender as a social construct, we found that the current curriculum looked at gender as a biological difference between men and women, not sex. So, if you remember Dr. Vibhuti's session today afternoon, so they understood gender as biological difference between men and women. There's very limited sex disaggregated data in the current curriculum, and therefore the gender integrated modules start with compulsory lectures around explaining the difference between sex and gender, understanding gender as a social system, introducing concepts such as gender norms, patriarchy, how that affects health, how gender intersects with caste, class, community, and sexual orientation, and also bringing in the fact that gender is not binary. So bringing in gender non-conforming people and their concerns and their health needs. Apart from that, gender bias has also been associated with, when we looked at the curriculum, all that the presence of gender discrimination or anything around gender was related only to female phenotype. And therefore, effort was made to introduce gender as a relevant category in all other subjects. So not just, sex selection and sex determination. There was no mention of gender as a social determinant of health. So there was no discussion in textbooks about how discrimination affects treatment seeking of women. This is a quote which some of you may find interesting. It is from the latest edition of Obs-Gynae textbook. When they're talking about anemia, they say that anemia in pregnant women speaks of faulty dietary habits and faulty absorption as defects attributed to the pregnant woman rather than gender discrimination that leads to an intergenerational cycle of malnutrition in women. So this is the complete missing concept of gender discrimination that exists in medical textbooks as well as the curriculum. And therefore, the steps taken were to bring in, points around how gender as a social determinant affects various different kinds of diseases, whether it's HIV, malaria, tuberculosis, so, non-communicable, communicable diseases. So that was something, a gendered analysis for every disease was brought into the gender integrated modules. Abortion, access to contraception and sex selection. Again, the curriculum was all around looking at, this conflation between abortion and sex selection. And therefore the gender integrated modules brought in evidence and a sensitivity to understand why women may report late. So why women seeking abortion may actually come in a second trimester. So it's not always post-sex selection, but it could be other factors such as geographical inaccessibility, lack of resources. So, the whole, that sensitivity was brought into the modules. There was an introduction to rights language. So questioning coercions for use of contraception. There was a whole content around conceptual clarity on abortion and sex selection. Apart from that, as we have, even Dr. Mala alluded to this, that medical teaching only focused on married women and abortion and contraception. So as if other women don't need it. And therefore, the content then looked at inclusion of sexuality as a concept and delinking sexual activity and marriage. So, principles of autonomy, bodily autonomy, privacy, and confidentiality were brought into the gender integrated modules. Apart from that, the whole curriculum talks only about family planning. And that was a shift in that was made by introducing the concept of contraception, replace family planning with contraception, because many people need contraception, not just those who are, married. And therefore, though that content and those modules have been developed. Also, promotion of vasectomy, looking at other methods of contraception, apart from only targeting women. So that was introduced. Gender-based violence is something which is absent in the medical curriculum, except you find reference to it only in forensic textbooks. There is a problem in the way that issue is really taught as far as sexual violence and rape is concerned. I'll talk about it. But the fact that, how do you sensitively respond to survivors of domestic violence and sexual violence was definitely a need that emerged based on the review of the curriculum, and those modules have been developed. There's a lot of prejudice and misconceptions about rape survivors, which exists in medical textbooks. And I will not go into the details of it. Many of you may know, otherwise we can also share information. And there are these papers that are published by the Economic and Political Weekly and also other publications of Sehat. So to address those misconceptions and prejudices, the entire content has been developed to bring in also scientific evidence around the two-finger test, the hymen, the fact that medical evidence you may not, what are the factors that might cause absence of medical evidence. There's this perception that through a medical legal examination, you will be able to tell whether a person has been raped or not, which is a complete myth. So that kind of content has been developed, and that's been included in the curriculum. There are also other ethical issues in practice, and there are modules developed around that. So sex verification tests termed as gender verification tests are still being taught in the medical curriculum. And so the lesson where this is taught now has an entire case study, and the whole content really brings to the medical students the fact that there is no single marker that allows for classification of people into either male or female. And all kind of concerns and issues related to these sex verification tests have been included into the curriculum. Also, introduction to sexuality and different sexual orientation. The curriculum focuses on counseling parents to carry out sex reassignment surgeries when children are born with ambiguous sex organs. And therefore, to kind of get rid of that, the module that has been developed is to really sensitize and make aware the medical students about what intersex condition is, the fact that there's no hurry to go in for sex reassignment, sex affirmation surgeries at all, and the fact that you need to follow protocol, allow the person to grow, and then let the person decide what is the sex affirmation that the person is looking for. Also, other issues related to obstetric violence in labor room, rights of women in labor have been introduced into this modules. Just to highlight that while this work was going on, the Modi textbook, which is seen as a Bible not just by the medical profession, but also by judiciary and lawyers, has completely revamped its chapter on rape. So some of you may know that the Modi textbook has a full chapter on sexual violence, or it's actually called rape. And it had a lot of stereotypes, lot of misinformation. So that's entirely been deleted. And now the chapter stands in a way that is absolutely appropriate and sensitive to survivors of sexual violence. So it includes concepts of informed consent, the autonomy of survivors. It talks about not getting into the past sexual practices of the survivor. It teaches medical students to focus on the history and not just mechanically carry out a medical legal examination. It also includes specific guidance on responding to survivors who come from marginalized groups, to how to sensitively respond to them. And it also talks about what is the first line of psychological support that doctors must provide all survivors of rape. So this is the kind of changes that have been made. And I will now hand over to Sangeeta, who will take us ahead in terms of what has been the impact and how Sehat takes it ahead currently.
Thank you, ma'am. Thank you so much for your presentation. Sangeeta ma'am, please go ahead with the presentation and we'll do the question answers later.
Okay, so we have a video. Shall I go ahead?
I was wondering, because after Padma's presentation, it would be a good idea now to show people the 5-minute film, and then I get into the presentation.
Right.
Sure, ma'am.
Medicine as a field has long been critiqued for being gender biased and not accounting for social determinants that shape health conditions, access to healthcare, and health outcomes. Gender bias does permeate many aspects of medicine in India, ranging from clinical practice to medical education. In the year 2014, Center for Inquiry into Health and Allied Themes, CEHAT, in collaboration with the Directorate of Medical Education and Research Maharashtra and the Maharashtra University of Health Sciences, embarked on a project which aimed to integrate gender in the undergraduate medical curriculum. The disciplines of gynecology and obstetrics, forensic science and toxicology, community medicine, internal medicine, and psychiatry were selected as they are considered core disciplines of the undergraduate medical curriculum. Medical educators were trained to integrate gender concerns into their teaching, make revisions to the curriculum, and spearhead the implementation of the revised curriculum. Assistant professors and associate professors from 6 rural government medical colleges and 1 private medical college were selected to become change agents. The participants played a key role in co-constructing knowledge. Lots of case studies, debates, and role play were employed to make the learning dynamic. All of this happened within regular teaching and working hours, so as not to add to the burden of these professors. A study was also undertaken to assess the project's feasibility. Was it possible to implement within the stipulated lecture time? Would students attend these lectures? Would these additions make a dent in transforming the knowledge, attitude, or practice of doctors? The answer to all of these questions was a resounding yes.
So I'm going to read some sentences, and for that particular sentence, you are supposed to tell me, is it sex related or is it gender related? Women menstruate. Sex, biology. Very good. Men are better at playing cricket than women are. Remember Smriti Mandhana, right? Women are gentle by nature. Gender, they are trained to do that, isn't it? The woman who is not gentle, immediately we start to are kasam mil gaye, right? Men cannot do housework. And men cannot control their sexual drive. We have a division of house, no? So let's do a vote. Who wants to say it is sex related? So you had change of mind. So are you sure it is gender related? Very clear. If it is sex related, it has to be same for every man. Is it same?
Medical educators accepted these gender integrated modules wholeheartedly because they found them complementary to the existing syllabus. Student attendance improved, and the entire training process resulted in a dramatic change in the mindset of the core group. The university had decided that they're going to incorporate gender sensitivity into the curriculum and begin at the grassroots levels with first-year students so that it happens. And we were happy to associate it with an NGO, Sehat, for this. If I have 150 students passing out every year, then they're going to work in the 50 other medical colleges in Maharashtra and maybe 500 medical colleges across the country. So if they have picked up even a bit of a spark, then that student is my ambassador there and also the ambassador for this cause.
I was a gender blind when I was groomed as a postgraduate student, as a faculty. But since last 4 years now, we are gender sensitive. If I apply a gender lens to my further teaching, definitely I can do the justice to the students and the women also. And this is what the change we brought in our department. But still, the medical education, now also the books, they are not gender sensitive. There are many books which are having still gender blind sentences. That has to be changed.
The Academic Council of Maharashtra has reviewed and approved this gender integrated curriculum, and a directive for implementation of the gender integrated curriculum has been issued in 2018 to medical colleges across Maharashtra. Till date, 300 doctors have been trained, and they in turn have transmitted this knowledge, attitude, and practice to their students, to nurses, and of course, their fellow doctors. A positive beginning has been made. Moving forward will require many more champions within each and every medical college.
Thank you, Arjun.
Yes, please go ahead.
Yeah. Good evening, friends, and we are at the last leg of today's session. I understand that all of you have been a great audience. You've been clued from 2:30 to almost right now. So my presentation focuses on the piece related to the action research. As Dr. Padma spoke about the entire project, the background, the training, I will quickly jump into how did we go about carrying out this study to really examine if gender can be integrated in the UG teaching and what are the results of those. So I'm going to quickly share my slides. Dr. Arjun, are they visible?
We can see it, ma'am. You can go full screen mode.
Yeah.
Yes, please go ahead.
Thank you. Dr. Padma has already spoken about the different themes, and these have been the methods that have been integrated in the supplementary modules. So traditionally and historically, many of you may know that the medical education is didactic in approach. And so for the medical teachers as well, it was a different initiative where they had to really become comfortable with using participatory methods such as role plays, quizzes, debates, and so on. So the planned research looked at these specific objectives, which relate very closely to the themes. To begin with, it was about recognizing how gender as a socially constructed concept plays out in access to health and healthcare. And after having taught this to medical students, whether there is any shift in their attitudes. Similarly, recognizing the impact of gender as a social determinant of health, understanding the issue of violence against women and students' attitudes to it, the issue of abortion, especially conditional access to abortion, contraception usage, and sex selection. And lastly, but not the least, how is it that students view ethical issues in clinical practice? So the methodology was that of a quasi-experimental research design, and the intervention was focused on implementing the gender-sensitive modules. Now, as you've seen in the film, there are 5 disciplines, namely internal medicine, community medicine, forensic science, gynecology, and psychiatry. You may all also be very aware that the number of medical teachers per medical colleges is dwindling since the last 10 years or so. So while we had to implement a research study, there was a requirement to have full faculty teach this gender integrated curriculum for a minimum of 6 months. And there were 22 lectures in all that had to be taken. On the basis of that, we had to, though we had a cohort of 7 medical colleges, it was only 3 medical colleges which had the full faculty. And that is how we went ahead with this research with 3 medical colleges. While we were testing these curriculums, the focus was for the purpose of research with 2 disciplines, namely the obstetrics and the community medicine. Other teachers continued to carry out the integration in their UG teaching, and interviews and experiences were documented separately, but they were not a part of this research study. So the methodology that we've used is the control group and the experimental group. The control group formed semester 8 students. Now, the way the medical education is divided, the first couple of semesters or year 1 looks at paramedics. It looks at pathology and all of those in the first 2 years. And the third year that focuses on clinical practice. So semester 6 and semester 8 are both semesters that look at clinical understanding of the medical education. Now, control group was semester 8, especially because they had gone through some aspects of clinical topics such as forensic medicine, community medicine, obstetrics, and so on. While semester 6 students had just entered the clinical arena. The reason for having both these semesters was that in this large study, it was impossible to have control groups and experimental groups to be compared against each other amongst the different medical colleges. And so this was best suited for the 1-year study. And so both control and experimental groups were formed in the same medical colleges across 3 medical colleges. Now, one of the most common methods for studying KAP, which is knowledge, attitude, skills, has been the pre and post test, and it's also been self-administered scales with nursing and medical students. So we have also implemented the same thing, which is like it's a scale that students have to take before the inception of the gender integrated teaching and after. This is done for both the control sample as well as the experimental sample. Now, this was the first time that gender was integrated in the UG teaching. And so we had to come across, or we had to design a scale that looked at measuring all the mentioned objectives in the previous slide. So there were 3 scales that we looked at, and they've also been popularly again used with a range of students, not just medical students. So the first is the Nijmegen Gender Awareness Scale, the second is the GEM scale, and the third is the Abortion Attitude Scale. I'm not going into the details of these scales. There is a research report that in detail documents the rationale for picking up these scales. But basically, all the 3 scales alluded to the research objectives that we were studying. In addition to these 3 scales, we had to also add about 5 to 6 additional statements that were not covered in these scales, especially issues around hysterectomy and so on. So in a total, we had about 51 statements. So if you see, this is the sample of medical students across 3 medical colleges. If you see the control and the intervention, as well as the division between male and female students. So the male comprised of 280 students. There's a larger number of female medical students, which is 348. And if you see in the post-test, which is post the intervention, again, the attrition has been not as high. It's only about 5, less than about 50 to 60 students if you compare the 628 to the 571 students. The methodology implemented for analysis is called difference in difference analysis. Now, why is this used? Because it helps to compare difference in the average outcome in intervention semester and within the intervention semester along against the control semester. So that's the kind of difference that we were seeking to measure. Of course, there were mean scores calculated for every single statement, but our presentation looks at thematic analysis. So we will go ahead with that. So first of all, if you look at the change in the gender attitudes, there is a significant change in the gender attitudes because medical students of semester 6 went through an additional lecture of 1 hour, which is focusing on understanding gender and sex, understanding that gender is not a binary, understanding gender identities, understanding sexual identities, and all of this has been taught to students in a participatory method through storytelling, through statements, and so on. And so we see high amount of retention and positive attitudes as far as their gender attitude score is concerned. If you look at the comparison between men and female students, we see that there is a better attitude amongst female students than men. Now, this has also been found in other studies because I think gender also disproportionately affects women. And so you see more positive attitudes in women than men students. And male students have also kind of thought that this issue is more to do with women because it comprises of the term gender. This is a graph that indicates the nature of attendance that was found through the entire research study. And it also goes to show, so the one at the bottom, which is the 0 to 20, 20 to 40, and so on, indicates the number of lectures that the intervention category of students attended. What this indicates is that the more the number of gender integrated lectures that students attend, the better is their attitude vis-a-vis gender. So the maximum number of gender integrated lectures were 22 in number. Those attending all 22 lectures had the best attitude as far as their gender awareness is concerned, as against students who attended only 2 or 3 gender integrated UG lectures. The second observation also made by medical teachers was that because they started using different methodologies to teach the existing curriculum, but with a gender lens, they slowly also saw an increase in attendance, something that medical students, something that medical teachers keep complaining, that there is very poor attendance amongst the medical students because most of them are busy studying for their PG seats. So this was another by the side observation made by medical teachers. Now we come to the specific thematic results. So these are the 4 different kinds of results. If you see, the first is about gender attitudes vis-a-vis the gender role of women is concerned. Now, as I said that the foundation or the additional lecture did speak about gender roles of men and women. These were not only integrated, these were not only a part of the additional lecture, but they were also integrated in other UG teaching subjects. For example, in a subject related to communicable diseases, or in a subject related to non-communicable diseases, they've actually spoken about how, or a subject related to family planning, they've actually spoken about the role of women in determining or not determining whether they can decide on the contraceptive method that they can use in their relationships. So all of these have been cemented in a manner that goes along with what is being taught to the medical students as far as their medical discipline is concerned. And hence we find a significant change and a better attitude amongst the medical students in this particular aspect. When you go to the theme on gender sensitivity, however, we do see a positive shift, but we do not find that significant. And one of the reasons is that the gender insensitivity, if I may say, is something that is very deeply rooted in the medical system. And there is a certain perception of patients which are coming to the, especially the public medical institutions and public health facilities. So we realized that while this was being taught to medical students, more concrete examples of how they should play out in clinical practice was required to be done, so as to then promote a certain kind of gender sensitivity. So of course, this particular lecture also looked at issues like HIV status of women and desertion, challenges with HIV positive women as far as accessing health services is concerned, or what are the reasons that they actually leave the treatment midway because there is no support from the family. But this was something that still kind of was understood in an abstract fashion by students, and they would have benefited if there was actual explanation on what are the clinical practice changes that students or teachers are expected to bring as far as their OPD and IPD duties are concerned. The other attitude was with respect, which is called as GRIP. This is especially with respect to how is it that medical students or doctors look at the stereotypes that they have vis-a-vis their patient population. Here too, we've not been able to find a significant positive shift, though there is a positive change in the attitude. That change is not significant. And this we again realize is because it's been decades of specific stereotypes that teachers or clinicians have about their patient population. So unless this is demonstrated through clinical practices or taught in a far more intensive manner, this is going to be a challenge to bring about a significant change in attitudes as well as practices. Lastly, we go to the graph related to the gender attitude with respect to abortion. Here we see a significant change in how medical students of the intervention category are actually viewing access to safe abortion. There is an increased sensitivity around the issue of access to safe abortions, also a better understanding that they should not be conflating the PCPNDT Act with the MTP Act, and so on. Now, this particular topic is being taught in both community medicine as well as in the gynecology and obstetric disciplines. Again, there are three attitudes here. If you see the attitude towards violence against women, you can see a significant jump over here. And this is because there has been an additional lecture that is being taught to medical students for the intervention category on violence against women. Along with that particular additional lecture, it has also been integrated in other subject matters and topics. For example, if there is a topic that is related to how does one provide antenatal care to women, within that there is an entire inquiry that has been integrated on violence faced by pregnant women. So these are different ways in which the issue of violence against women has been associated with health, and it has been cemented in the teaching of medical students. And so one sees a significant jump over here. Lastly, if you look at the gender attitude as far as sexuality is concerned, the MBBS curriculum is largely silent on the topic or the concept of sexuality. The MBBS looks at sexually transmitted infections, probably as Padma said, also in the forensic discipline, it is about rape examinations, but there isn't any nuanced understanding of what is sexuality. And so medical students often associate sexuality with illness. And hence this entire issue is a very, very new issue for them. And so we feel like the understanding of sexuality does take time. And so you see again that there is a positive shift, but there is not a significant attitudinal change as far as sexuality is concerned. These are the different feedbacks reported to us by medical teachers in our conversation. We went back and spoke to all the medical teachers who taught 20 plus gender integrated lectures in the UG teaching. Most of them, or I would say all of them, were appreciative of the different innovative methodologies that they were able to use, something that they say they had not used in the past. They find that this is highly feasible intervention because except for the two additional lectures, one, the violence against women lecture and a lecture on gender and sex, all other lectures or all other additional gender content is integrated in the existing lectures. And so there is high feasibility. And I mentioned about the issue of also consistent attendance, something that they observed because of the change in methodologies also that they had applied. So in a nutshell, the findings indicate a consistent positive shift in the attitude of medical students in the intervention categories across the different themes, though a few themes have not found the attitude change significant. And like we mentioned, that there is a need to work some more on those aspects. Finally, of course, we would like to say that the issue of gender cannot be relegated to a standalone lecture or an elective module. This is something that needs to be consistently reiterated across different disciplines, across different semesters, as well as integrated in clinical practice changes. Only then the entire understanding of gender within UG teaching and gender in clinical practices will become more permanent. I have picked up some of the students' feedback from one of the medical teachers who taught gender integrated lectures in their UG teaching. So I am not going to read each of these, but this is what the students had to say about the lectures conducted. They felt that the batch was enlightened. They also understood that GME lectures are a good initiative to sensitize the medical students as well as the fraternity regarding a more tender approach towards female patients. They found the lectures as inspiring. They also said that if they were not made aware of this inequality, then many of them would have gone the same traditional way. Here they speak about 21st century biases as far as the gender aspects are concerned. Yeah. So as I said, that this is a research study that clearly said, indicated high feasibility to teach medical students within the limited hours of UG teaching that are existing in the MBBS curriculum. Now there are very clearly two very important opportunities that we have. One of them is, of course, the SDG, where the entire claim is that we have to try and achieve gender equality by 2030 and so on. But clearly the one that relates to medical education is the competency-based medical curriculum. There has been a huge shift in this competency-based curriculum. In fact, now there is an additional lecture or a foundation lecture that will be taken for semester 1 students. The title of the lecture is Gender Empowerment. Now, while this is not enough to inculcate gender sensitivity in medical students, it is a beginning. And this has created a huge opportunity for Sehat and other organizations who are engaged in the field of gender medical education as well as clinical practices, an interest by medical colleges to take on these kind of gender integrated lectures. We at this stage are at the level where we have now, besides the 7 medical colleges, additional medical colleges in Maharashtra, which are integrating gender in UG teaching. There is a new component that we have integrated in this entire endeavor, which is now moving from the UG education and bringing about a change in clinical practices. So by that, I mean changing harmful medical practices in consultation with medical teachers. And last but not the least is also about creating research fellowships for medical teachers. Because if you look at the entire, journey of medical teachers from the time they join the medical colleges till the time they retire, hardly any research is done as far as gender and access to health, gender and impact on health or health-seeking behavior. Hardly any research studies in the Indian context are being done by medical teachers. So this is something that we are promoting and looking at doing. As far as upscaling is concerned, the work in Maharashtra has inspired other states to also follow suit and implement similar curriculum in their own medical colleges. So we've just begun the entire endeavor with Karnataka and Telangana medical colleges this year. This is the virtual center. It's a website. For all of those who are interested, please do log into the website. We have the most recent works of gender in medical education. There is a lot of material available. There are papers, there are methods, there are modules, there are short films. So please do feel free to access it or write to us. And thank you so much for the opportunity, Dr. Vibhuti and friends at IMPRI. And we are ready to take any questions.
Sure, ma'am. Thank you so much. I would like to thank Sangeeta ma'am and Dr. Padma for giving us such an enlightening presentation and touching up on crucial issues related to medical education. We have few questions, one in the chat box. Nandini Murliji is asking, integrating gender into UG medical curriculum has been a great leap forward, but what would be your thoughts on integrating the lived experiences of people into the curriculum as a valid and valuable means of knowledge? Ma'am, please go ahead with the answer.
Padma, you want to take that?
Yes, thank you, Nandini. And I think the effort here is to bring in lived experiences. So it would be interesting if you, dwell and you also interact with some of these medical colleges that have integrated gender. So they have found very innovative ways of doing it. So that, like Sangeeta said, the gender integrated modules are being taught using very different methodologies. So these are not just pure lectures. So there are reflections, there are case studies to really bring in lived experiences. I can't agree more that that is what is required for sensitizing medical students.
I think there's a question related to gender disaggregated control and intervention data by Susrita. So we'll share the slides, Susrita. My second slide spoke about sex disaggregated data, number of men and number of female in the intervention and control groups. I hope I've got your question right. There's a question on dental education.
Yeah, sorry, Sangeeta. I just wanted to understand that when you measured the across these different themes, do you see that male male, female students, or even if you had non-binary students, was there any difference? I see there is not, overall also there is not significant difference, but somehow I wanted to know if there is anything that you could have, highlighted, that some places where maybe the women student had a little more interest, like maybe gender-based violence, the significance could have arrived, something like that. May or may not be. I'm just, this is a thought. Yeah, thank you.
Yeah, sure. I mean, as you've rightly pointed out, in themes where there is a change, a positive shift in attitude, but not significant, it is similar for men and women. For example, sexuality. But in the piece on the violence against women, there is a significant change in the attitude of both men and women. But with women, the attitude fares even better. And that's there in the research report. I'm sorry, I've not put each of the themes and the men-women disaggregation as far as the attitude score is concerned. And so, Srita, unfortunately, none of the 200 plus students at least identified themselves as any gender minority. So we don't have data on that.
Ma'am, there are some questions who have been asked, and Mary Sinju has raised her hand. Miss Mary, please go ahead and ask your question.
You can unmute, no, and switch on their video and speak. Mary Chinsu.
Mariji, can you unmute and ask your question, or Alka?
Yes, can I go?
Yeah.
Yes.
Hi. So thank you very much for wonderful.
You can also start your video.
I don't know. I don't have that option.
Okay.
So thank you very much for insightful discussion going on here. Basically, I have two questions. I have covered where Kerala trans medical students filed a case petition, and then the virginity test ongoing controversy in medical syllabus. So I was trying to follow up with NMC a lot, but trust me, there is no communication from NMC. So I just wanted to understand, instead of engaging colleges, can we have discussion? I mean, you have discussion with NMC, and then strict guidelines could be issued to make these changes, because in both cases, they have issued guidelines with one letter. But on ground, the syllabus is same. Old syllabus is used even today, which is homophobic, which is transphobic, and which is, encouraging two-finger test and virginity test. That is my only question. I mean, what can we do on national level despite filing petitions and all?
I don't have a clear-cut answer, but I would love to respond to it. Sehat, before the NMC was created and when MCI was valid, all of these supplementary modules, after MUHS stamping them as effective, were taken to the MCI, and we requested that these be provided as supplementary material to all medical colleges of India, so that gender is kind of integrated across different states. At that point, we were met with, I would say, hostility. To say that, you're diluting the medical education. Today, you're asking about gender. Somebody is asking about ecology. Somebody is doing that. At this rate, the entire medical education will get diluted. Despite all our efforts at that point, all that they agreed was to integrate that one single lecture in semester 1, which you now today see as gender empowerment in the CBME curriculum, right? So what we found effective as far as replicating the Maharashtra work is going to different medical colleges who are interested in implementing this, creating some kind of championship where medical teachers on the ground find that they have a stake, find that this interests them. Because as far as your own experience of competencies are concerned related to gender and sexual diversity, they have been submitted by a 3-member committee to the NMC. Medical colleges are yet to receive a formal approval saying these are going to be implemented. Now, as far as all the other competencies are concerned also, there are no clear indicators for measuring these competencies with medical students, right? So you have a very fancy CBME curriculum, but the 8 core module, which is about doctor-patient relationships and softer skill communication issues, has not been implemented in the past 3 years. So there are lots of gaps as far as the rolling out of the new curriculum is concerned. I'm only adding a complexity to it. No answers really.
Right. Alkaji has raised hand.
No, I'm done. I had a question. I just discussed it. So I'm done.
I think Professor Veena ji has raised a hand.
Yeah,
please go ahead.
I did. Yeah, I did. So it was like taking a ship back into 20 years, and then through the curriculum of gender we have sailed through, because I was the first lady in forensic medicine in Karnataka. And then we used to spend time, lot of time, on virginity test, types of hymen. What are the different types? And in what way is it relevant to you in any way? But then they used to say, if you're so sensitive, don't take subject forensic medicine. So from that on, 25 years later, I just had 1 month back I made a seminar for 2.5 hours. And one of the new joined in forensic medicine, she came from up north to meet me and say, I want to be inspired because at this point, I'm very depressed. I don't want to be in forensic. I said, what happened? I said, because during my time, they used to ask me, didn't you find a better subject like gynac? Why did you take forensic? She said, exactly, they asked me the same. And that depressed me, actually. I was thinking there'll be some change in the way, but I said, depression doesn't help. Then we should step up. We should do something to overcome this, because if we don't only look at the syllabus, but even look at how most of the questions are around these. Like it's making a reader read this much more than anything else. Once, literally during exam time, a girl was near tears because they only went on asking her about rape. How do you prove a rape case and things like that? So I said, sir, forensic is much beyond rape on sexual distinct, but question is, that is how we are ingrained into, like I said in my presentation, when we are brought up, we are already brought up with a bias. We have a biased lens. Unless we question our own lenses, that we clean up our lens and question our bias, where am I in relation to this? Where am I in relation to gender? Where am I in relation to transgender? And what do I think about these tests? Virginity test, is it to be done? Or the types of hymen, are they to be discussed in forensic? And never ever you think of giving a humanitarian hand to a lady who has been gang raped. Because you see, that's not for forensic. So somewhere the humanity we are getting far from, law we think we are so close to, and court is the closest relation we have. So that is, the medical education was never meant to take us away from the suffering. It was supposed to put us. So what if we are translating our knowledge into court, but that can't be away from patient. It can't be against the patient. So I think it's a very beautiful way you brought up, and Sangeeta and Padma, it was really, it's something that really touched home with me. And same thing with you and what Vibhuti madam had brought up. Such a complicated thing, but she made it look like a flowing river with all the intricacies. and so is with Mala. So I think it all adds on to one particular thing, that this is begun, especially when it comes to medical education. You have done a good job, but the question is, we need to carry it forward. So it is we who are the torch bearers. We can't look at you and say, what did you do? But the question is, what are we doing with what you did? So how are we taking it? So that is to be decided by us.
Right. So,
Thank you, ma'am.
Yeah,
I think Mary Sinzu is there. Are you there, Miss Mary?
She's
Mary,
not,
please speak up.
yeah, she's not responding.
Okay, maybe she's not there. So I think we are done with the questions for ma'am, Sangeeta ma'am and Padma ma'am.
Ananya ji has raised the hand. But Sarvi, can you check the chat box? Some questions were there.
That has been answered.
Okay.
That has been answered by Padma ma'am. So I don't think there are any more questions on the Q&A as well. So with this, I would like to thank both Sangeeta ma'am and Padma ma'am once again for the presentation and addressing all the questions. I would like to invite you for giving the concluding remarks.
There is a question by Sushrita Roy. She has raised hand. Mary also has raised hand.
Yeah, sorry, I had a question for Dr. Padma regarding
there in the question box.
Yeah, I was asking Dr. Padma, do you see that engaging with IMA or Foxy, because I think when we are all students, as students, we have priorities of passing an exam, and such additional courses which are not aligned to what we came in for may not be that kind of may not have that interest. But when you have progressed and you have almost established yourself, so that's where the IMA and Foxy can, where there you can introduce. And when those faculty members, those people who are already established in their profession, they take this up a little more seriously, not maybe like a course, but maybe more engaged with it in whatever form they are, and then they come back for their guest lectures or something, then the students will get interested. Do you see a possibility? It's just a random thought I came.
Yeah, I actually answered that on the question answer panel. But anyways, I can just respond to that saying that, I mean, your question, yes, should they be involved? Yes, they should. Are they interested? No, they are not. Have we tried? Yes, we have. So, who runs the IMA? Who's running Foxy? What are their interests? It's largely commercialized, all these associations. So nothing stops them from embracing a gender perspective. Nothing stops them from taking up these modules. Nothing stops them from issuing directives, taking forward the Madras High Court or the Supreme Court judgments. None of it. So that's, yes, of course, they must take leadership.
Ma'am, would you like to make some concluding remarks?
Mary, you have also raised hand, no? Mary, is she there?
No, she's not there, ma'am.
Okay.
She's not responding.
Yeah.
Try again. No.
So concluding remarks are from Professor Veena Vaswani. Yeah.
That's a tall task, ma'am. I think you would have done well with that. Yeah. So to begin with, although I can say that, no, but I'm going to hand it over to you so soon. So coming to the end of today's discussion, it's we are just trying to get together the ideas about when it comes to gender, the entire canvas that we started with, the way of human dignity, human rights, and then bringing into a theory of through identity, social identity, and how we assume the superiority it's given and the sufferers suffer, and then Mala bringing in the reproductive rights, and in a way where reproductive rights are not just about contraception, but how is it made, how much is she empowered to make a decision, and what are the host of other things that you have to make it convenient, comfortable, feasible, accessible, so that it can be utilized. And then we also faced about the setback that of late, when you think of contraception, that will not be free, but it will be commercialized, and the way it might impact. And over a period of time, when we are only looking at the fertility rate or the one particular indicator, you lose the sight of a bigger picture. So the discussion, when it is to be done, is not to be done by people sitting on the ivory towers and making shots, but rather taking people into consideration who are immersed into doing this and understanding, knowing the broad picture of how it impacts. Because if at all we are losing something, we are losing a big picture. We're just looking at a small plant and say this is the wood or the forest. So this should not be happening. And also Vibhuti madam, again, it's such a complex thing, but she brought into how best we can make the possibility of a working condition, how we can improve upon the gender inequities. So the more you think about it, more you feel there is enough place for a constant action from us to take on from here as a jump pad, And also Sangeeta and Padma brought about the medical curriculum, because after all, we are churning out 40,000 to 50,000 doctors every year. And when they come out, if they are not just doctors, it is a society that gets injustice. But the worst part out here, there is no court. And we assume and we are immune to injustices because that is what is happening everywhere. We can't help it. But this is propagated if we don't take a proper steps. So I think overall, today's presentations to me have been very moving and they're very meaningful. And we can take a step forward into this, that how best we can use it more into action related things. So over to you, Vibhuti ma'am. I have kept a lot of loose ends.
I think the main learning of today's 3 presentation is that we need to build bridges. I remember 40 years back when we were talking against two-finger test, we were completely humiliated by the medical fraternity. And they said that we did not understand, we are the lay people. And look at what Sehat team has achieved, Sangeeta and this, the people are listening to them. I know the painful processes through which they have gone through, how they have faced the misogyny and extremely sexually objectionable remarks from the governance, people in power, all that they have won. So it's not so easy, but they have done it. And I think that's what makes us confident that if we build bridges and have interdisciplinary perspective, where the social workers, medical professionals, women's studies scholars, and social theorists come together, then I think we can make the changes. And I think these transformative processes, these gender transformative processes in which we need to have more and more allies. So I think that is the major learning of today's session. And I think it was an excellent thing because it had component of research, we had that component of training, sharing, knowledge sharing, all the knowledge products which have come out of painful experiences of first-hand experiences, participatory research experiences, and the Sehat's experiment of a random control trial, which is the most fashionable research methodology currently after Professor Banerjee got his and Madam Professor Duflo got the Nobel Prize. But I think we can use it for such important learnings. And I think the achievements that we have had both in the from shifting from reproductive control to reproductive rights, because what was the situation in 1977, except for horror stories of population control that we heard of those 18 months of emergency rule. From there, we have come to the reproductive rights. Mala's presentation brought out that whole historical sequencing of the events that happened in the area of reproductive rights of women and reproductive autonomy, bodily integrity. So the language itself is changing because medical science is one which I found the most authoritarian. Even when the informal discussions among my husband's friends used to take place, I used to find it extremely, as a social scientist, I used to find it very, very authoritarian, regimented, no questioning. As I said, the whole patriarchal model of doctor as a father, nurse as a mother, and patient as a infant, child, no? And infantilization, the issue of that also came up. So I think I found this for 3 hours extremely rewarding, and we made it due to our collective endeavor. And I'm really happy at the end of the day because IMPRI team has been working for past 6 weeks to put this workshop in place, and we have got tremendous response, nearly 60 plus registrations, and even participants are interdisciplinary. They are from various professions and various disciplines.
Thank you, ma'am.
Finished on time. I was rushing my presentation because, so I think all of us have managed time because we teachers are programmed to speak for 2 hours minimum. PG. So one has to really do the time budgeting in a proper, and we did that. Yeah. And thank you for the participants. We had earlier kept time every 15 minutes break after each lecture, but I think we did not do it today because I think there were many, because it was for inauguration also we needed some time. But just give your opinion whether you would like break after every lecture because we in the timetable we have announced 15 minutes break.
Thank you, ma'am. Thank you so much, both Veena ma'am and Vibhuti ma'am, for the closing remarks. So next Saturday will be our day 2 session of this excellent training course. And we have another set of distinguished experts. They are Dr. Ketki Ranade, Dr. Amar Jasani, and Brunel D'Souza. So all the readings for the background has been provided by our experts, and it's already emailed to you in your respective emails. So as we come to end of day 1 of an immersive online certificate training course on perspectives on gender through healthcare lens, I, Sauravi, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of Center for Ethics, Yenepoya, and IMPRI Gender Impact Studies Center. We are grateful to our eminent expert trainers, Professor Vibhuti Patel, Professor Veena Vaswani, Professor Mala Ramanathan, Dr. Padma Bharti Diostali, and Ms. Sangeeta Reke for their insightful sessions. We thank all of our participants who have raised pertinent questions and actively involved in today's deliberation with us. We would welcome you once again on June 11 and look forward for very enthralling and knowledgeable experience. So we hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you a good evening. Thank you.
Thank you.